Okay. Okay. So, good morning, everyone. I'm Dr. Singaram. So, I hope the audio and video, everything is clear. Is anybody having an issue with the streaming video or audio? Please let me know. Okay. Is it live? Okay. So, is it live? Because students are asking. Okay. I hope I'm live. I'm live now, right? Okay. So, yes. So, good morning, everyone. I'm Dr. Singaram. I hope the video is okay. And audio and video, there are no issues with the screen also. Please let me know so that I can get started with the class. Yeah. So can we get started? So yes. Just let me know in the comment section or chat section so that I know that everything is fine and we can get started. Is there any issues? Yeah. I don't know. Like if there are any issues, please let me know, or else I will get started. Hariom, is it okay? Can I start the class? Hariom, is it okay? Yeah. Okay, fine. So I think we'll get started now. If there are any comments, please let me know in the chat section or the comment section. Okay, right. So hope there are no issues. Can we get started? Right. If somebody's is online, please let me know by message if there are any issues or something so that I can get started. Because I don't see any messages, so your queries will be coming in that chat section only. So please let me know so that I can follow it up from there. So anyway, I think it's already online, so I will get started. Please let me know in the comments any section. Okay, so I hope all of you have received the workbook, the PDF which I have shared. So yes, okay, right. So I think now I'm able to see all the comments. Okay, fine. It is fine. Okay, so I hope all of you have seen have got your workbook section. I will be covering 3 chapters for you in medicine section. One will be cardiology, another one will be respiratory, and third will be the nervous system. Plan is to do respiratory system today. So you can start from the worksheets which I have given. That would be in page number. I'll just take up the page number. Page number will be 25. Page number 25 in your worksheets which I have given. Okay. Yes, page number 25. Okay. I hope all of you have taken that page number. It will be about the respiratory disorder section. The plan of discussion will be to discuss about the important topics in each of these systems. I will be covering a little bit of basics in each of these systems, and then I will go into the disorder section. So that will give you an idea about the basic physiology of the particular system, and then when we go into the disorders, it will become easier for you to follow. Right. So every discussion will be according to the recent pattern of questions, which I think most of you should be knowing will be clinical pattern questions. Okay. So as I keep discussing, I will tell you about what are all the important features in each of those disorders which are highlighted and asked in the exams. And towards the end of the chapter, I will put up some MCQs also, where you will see those type of questions. Okay, that is a clinical scenario type question which we will be solving at the end of every chapter. Okay, right. So this will be the scheme of discussions. I will be taking the class till evening around 5:30. So we will have adequate breaks in between. Every 2 hours we will have a break. And please focus on this because good number of questions are expected from the medicine section. Cardiology, CNS, and respiratory are like very good number of questions. Okay, at least 10 to 15 questions you will get from these 3 chapters itself. Okay, right. So that is why you should know about these chapters. Let us get started. I hope again, yes. Okay, right. So I hope there are no issues with the video and audio. So I'm getting started. Okay. Any comments or any doubts in between, please put it up in the chat section. I am able to access that in my mobile. So I will be clearing your doubts also then and there. Okay, right. Fine. So let us get started. So the first one will be about in the respiratory disorder section. It's a basic chapter of lung function testing. I hope that your physiology classes has been taken for the online batches. This is basically a revision of that. Okay, right. So any comments on what I'm going to talk about in the lung function testing? Okay, it will be something called volumes and capacities. It is something called as the volumes and capacities. Okay, volumes and capacities. I'm sure few things have been taken in your physiology sections. Okay, volumes and capacities. Correct? It has been taken. Is it over? Your physiology classes are over? Fine. Okay, right. So what I will be basically talking about is the volumes and capacities. Now, not everything they have covered in physiology I will be discussing. Only things which are relevant for clinical distinction I will be making a note of. Okay, and this is based on spirometry. This is based on spirometry. Okay, right. Now, spirometry, if you look at it, there are basically 2 types of lung function testing actually. One is called as a static lung function testing. One is called static. Another one is called dynamic. Okay, static means something like a fixed number. That is what it is. Okay, static is something like fixed number. Dynamic is something which will change with time. Okay, it will change with time. Okay, it will increase or decrease with time. So based on the time, like we typically express now 1 second, 2 second, 3 second like that. That is what's called dynamic testing. Okay, and what is important clinically? Static testing or dynamic testing? It is a dynamic testing which is important clinically. Very important. Okay, dynamic testing is what is important clinically. So that is what we will be discussing mainly in the following section. Okay, right. Okay, so this is how it is going to work. I am going to put it up in a very simple way. What we should do is we should ask the patient to take a deep inspiration. Okay, deep inspiration and ask him to exhale out. Okay, deep inspiration and ask him to exhale out. Okay, right. It is fine. If physiology is not over also, it is fine. I will try to tell you from the basics only. Okay, so don't worry about it. It's all simple things only. Because once you understand this topic, it will be easier for you to follow when I discuss about the disorders later on. That is why. Okay, right. So again, coming to the point, dynamic lung function testing is what I'm going to focus on. It is something like, as per the time, what is the volume, what is the capacity? That is what we are going to look at. So how it is typically done? It is done by asking the patient to take a deep inspiration and then ask him to expire out over a period of 6 seconds. Can you see that? Over a period of 6 seconds. So it is not like immediately they will expire. No, over slow expiration over a period of 6 seconds. Okay, so deep inspiration followed by the expiration. And what you will get is typically a graph like this, where on the x-axis, okay, this side, you will have the time, which is measured in seconds. Time which is measured in seconds. Okay, I think like this. This is the 6 seconds. 1, 2, 3, 4, 5, and 6 seconds. This is the time measured in seconds on the x-axis. Okay, right? And what you will have on the other side will be the volume in ml in the y-axis. This is how it is. Okay, this is what we call as a time volume curve. And typically, how does this curve follow a pattern like this? Something like this. Any comments based on this? Any comments based on this particular graph which I have drawn? Can you see that the amount of volume expired? See, this is the volume of the air which is expired after a forceful inspiration. Can you see maximum amount of air has been expired initially only? Can you see in the first 1 or 2 seconds only, most of the air has been expired. And after that, only very minimal amount of air is coming out. I hope you can follow this. Okay. So this is what is the logic, that whenever we expire out forcefully, maximum amount of air comes in the first 1 or 2 seconds only. After that, only very minimal amount of air only comes out. And can anybody comment on what is this? What is this which I'm marking now? Any comments on this? Any comments on this? What is this volume? What is this volume? Any comments on this? Look from the graph and try to tell me an answer. Look from the graph and try to tell me the answers. Yes, anybody? It is the amount of air which is expired in the first second. Any name for this? Any of you know any name for this? Any name for this? It is called FEV1. Okay, it is called FEV1. What is that? It is nothing but forced expiratory volume. Forced expiratory volume in 1 second. That means the amount of air the patient has expired in 1 second. That is what we call FEV1. That is a very important measurement which you should remember. And what is this one? What is this one? At the end of 6 seconds, how much of air the patient has expired? Any idea? What is this one? Which one? Dead space volume. No, it is not dead space volume, doctor. Just a minute. Okay, it is not dead space volume. I'm asking, what is the amount of air which is forcefully expired at the end of 6 seconds? That is complete expiration. What do you call that? This is what we call FVC. What is this? It is forced vital capacity. Forced vital capacity. So from this curve, you can know 2 things. What are the 2 things? One is FEV1, another one is FVC. Okay, that is what you need to remember. Okay, forced expiratory volume in 1 second and forced vital capacity is the total amount of air expired after a forceful inspiration. That's what you need to remember. And we always calculate a ratio between the two, FEV1 by FVC ratio. And the other name of this is called Tiffany index. Okay, can you see that it is also called Tiffany index? That is a name for this FEV1 FVC ratio. Okay, right. Any comments? How much of the air is expired in the first second? FEV1 by FVC is what? It is the amount of air expired in the first second when compared to the total amount of air which is expired. Any idea how much amount of air is expired in the first second? I told you, most of the air is expired in the first second only. So I am just asking how much percentage would it be? Will it be 100%, 50%, 60%? Any answers for that? Okay, it is 70 to 80%. What I'm trying to say, whenever you are expiring out the air, 70 to 80% of the air is expired in the first second itself. Are you able to understand this? That is what is the simple meaning of FEV1 by FVC ratio. Clear? Okay. Or in other words, if you want to remember it in whole numbers, it is 70 to 80%. If you want to remember in whole numbers, it will be 0.7 to 0.8. That's all. 0.7 to 0.8. That's all. This is the normal FEV1 by FVC ratio. Okay. Right. Now, in case of lung disorders, we try to divide them into 2 categories. Okay. One is called obstructive lung disease. Another one is called restrictive lung disease. Okay. Right. I will explain about this. Simple. Obstructive lung disease means whenever there is an obstruction or the block to the flow of air, it is either the flow of air going in or flow of air coming out. Something like that. There is a block. That is what is called obstructive lung disease. What is the meaning of restrictive lung disease? Restriction means it is something like the lung itself is restricted from expanding. See, only when the lung expands, good amount of air will come inside. Are you able to follow this? Here, the problem is air itself is not allowed to come in due to restriction of the lung. That is what is called restrictive lung disease. So very simple. Obstruction means air can be able to come in easily, but not able to be expelled outside easily. Whereas restriction means the amount of air coming in itself will be very, very restricted. Okay, that is called restrictive lung disease. Okay, I have given some examples below. I will talk about that example, but just wanted you to know about the idea or differences between obstructive and restrictive lung diseases. Okay, right. Now try to comment on this. What will happen to FEV1 by FVC ratio in case of obstructive lung disease? Simple question. What will happen to this ratio? The first ratio, this one. FEV1 by FVC ratio in case of obstructive lung disease. Simple question. Any comments? You can type in your answers in the chat section or the comment section. Any idea, anyone? Okay, very simple. What is happening? There is an obstruction to the flow of air outside. So obviously, the amount of air expired will be lesser. So this ratio also will be less. Are you able to follow? This ratio will be decreased. It will be less than 0.7. That's what I want you to remember. Okay. Whereas in case of restricted lung disease, I told you the amount of air entering only is the problem. The amount of air expired is not a problem. So it is usually normal. It is usually normal. Okay. And there's only one thing which I want you to concentrate. Sometimes what happens, the amount of air entering in restricted lung disease is less, right? So what the body will try to do, the body will try to expire forcefully so that it can intake also more forcefully. So sometimes this can result even in an increased FEV1 by FVC ratio. That is more than 80%. Sometimes can be there. But if you remember broadly that the FEV1 FVC ratio is decreased in obstructive lung disease and FEV1 by FVC ratio is normal in restricted lung disease, that also is enough. That's what I want you to remember. Okay, next one is called PEFR. Any idea what does this PEFR stand for? PEFR stand for, I will just write by the side. PEFR, yes, correct, Dr. Atul, correct. PEFR stands for peak expiratory flow rate. Peak expiratory flow rate. Okay, right. I will try to explain it a little later, but it is very simple. What is this peak expiratory flow rate? Peak expiratory flow rate is the amount of air expired forcefully at its peak. That is what is called peak expiratory flow rate. I will try to explain this with one more example, which is in the next page. Okay, please take the next page. Please take the next page. Take the next page. Okay, I will again come back to this. I have not completed it fully. I will come back to this. Look at the next page. This is what we call it as a flow volume curve. This is called flow volume curve. What I have put up is a normal flow volume curve. You just remember like this. This would be the volume, x-axis, and this would be the flow. This would be the flow. Okay, this is called as a flow volume curve. Okay, so let us try to understand what is this. Here also the same thing. With the help of the spirometer, we can do this flow volume curve. What we should do is we should ask the patient to take a deep breath and then ask him to exhale out forcefully. That is what we are trying to do. Now, please try to get the orientation. This is how a normal flow volume curve would look like. But I would want you to remember like this. The volume will be in terms of liters. Please make a note of this. Volume will be in terms of liters. And see carefully how I'm going to name that liters. It is not like from here I'm going to write 1. It is not like from here I'm going to write 1, 2, 3, 4, 5, 6. No. Rather, I'm going to write the volume this way. This is how it is usually depicted. Okay. From the right side to the left side is what I'm going to depict this volume as. So how it would look like? So listen carefully. This would be 0. This would be 1 liter, 2 liters, 3, 4, 5, and 6 here. Think like this. This is how it will be. Okay, right. Just to give a good spacing, I just draw this again. Okay, 0, 1, 2, 3, 4, 5, and 6. This is what it is. Okay, so this is how it will appear. Please remember, it is from the right side to the left side. So please make a note of this. And the curve would typically look like this. The curve would typically look like this. This is how it will look like. I'm trying to explain it. Please draw it first, and then I will explain it fully. Okay, right. So this is how it is going to look like. This is the normal flow volume curve. Please remember the direction. Look at the direction, how it is going. It is like this, and drawing. It is like this. I'm able to follow the direction. Okay, this is like this from the below, and then it goes above. And the limb which is below is what we call inspiration limb. This is the inspiration part. Please remember like this. Initially, we take air inside, right? So this is inspiration limb. And what is above? Okay, this is what we call it as an expiration limb. Above is called as an expiration limb. Please make a note of this. Okay, inspiration and expiration limb like this. Okay, fine. Just a minute. Okay, so below is inspiration and above is the expiration. Okay, I hope you're able to follow this. Okay, inspiration below and expiration is above. And what I want you to remember is few important points here. Okay, see, what is this full area called? Any idea what is this full area called? The amount of air which is forcefully expired. Tell me based on whatever I have told you till now. Showing. Yes. Okay. Not able to see any of your comments. Okay, fine. So, any idea what is this area which I have shaded now called as? What is the area representing? It is the amount of air which is forcefully expired after a deep inspiration. What is that? It is nothing but FVC. It is nothing but the forced vital capacity. That's what I have told you, right? It is the amount of air which is expired forcefully. That is what's called forced vital capacity. Okay. Anything else is there? Anything else is there? What is this point representing? Look at this. What is this point representing? What is this point representing? Yes, any comments? What is this point representing? This point is the peak flow at the time of expiration. This is what we call PEFR. What is that? This is called as a peak expiratory flow rate. Are you able to follow this? It is a peak flow at the time of expiration. There is a peak point at the time of expiration that is called peak expiratory flow rate. Okay, so I hope you're able to follow this. Okay, right. Now, anybody comment on this volume? I'm marking like this. This area, this volume as number 1. Any comment on this? What is that point representing? What is the point representing? Okay, it is something like this. You have asked the patient to take a deep inspiration. Followed by that, you're asking the patient to do a deep expiration also. And at the end of full expiration, this is the volume which we are talking about. What is that volume? Simply, you remember one thing. Even if you try to forcefully expire out also, can you expire out all the air inside the lungs? Or will some air remain inside the lungs even after a forceful expiration also? The point is, even after a forceful expiration also, there will be some air remaining inside our lungs. Our lung cannot expel out all the volume outside. Can you see? That is why I have not marked the point as 0 ml. No, I have not marked it as 0 liters. 0 liters means what? No air is inside the lungs, correct? No air is inside the lungs. But it is not so. There's always some amount of air inside the lungs, even after a forceful expiration also. And as Dr. Satyan states correctly, this is what we call RP. What is that? Residual volume. Very correct. This is what we call RV. Number 1 point represents RV. RV is nothing but the residual volume. Very correct, doctor. Residual volume. You can also write what is the meaning of that residual volume. Very, very simple. Residual volume refers to volume of the air in the lungs at the end of forceful expiration. Are you able to follow this? At the end of forceful expiration. That is what is called residual volume. Volume of air in the lungs at the end of forceful expiration. Okay, this is called as a residual volume. And you can see from that picture itself, it is something between 1 and 2 liters. To be very exact, it is around 1.2 liters. This is the amount of residual volume. Yes, it is fine. If physiology is not covered, it's okay, doctor. That is fine. I'm just trying to explain only. Okay, right? This is called as residual volume. This is the volume of air in the lungs at the end of forceful expiration. That's all. That is what is called RV. Then, any comment about this one? Any comments about this volume, which I'm marking now here as 2? What is that 2? The 2 is nothing but the amount of air in the lungs at the end of forceful inspiration. Can you see that? You ask the patient to take a forceful inspiration. At the end of forceful inspiration, you are asking you are checking for the volume. Any idea what is this called? You are asking the patient to take a deep inspiration, and at the end of deep inspiration, you are checking for the air inside the lungs. That is what this point 2 is representing. What is that? It is something called. Any comments? I'm waiting for the comments. Anybody? Yes. This is called TLC. What is this TLC? It is called total lung capacity. Total lung capacity. Okay, it is called as a total lung capacity. Please write that. Can you see that? It is called total lung capacity. You can also write what is the meaning of that. It is nothing but volume of the air, okay, in the lungs at the end of maximal inspiration. Correct? At the end of maximal inspiration, the amount of air inside lungs is called total lung capacity. And can you see it is somewhere between 5 and 6 liters? Can you see that? It is somewhere between 5 and 6 liters. So to be exact, it is 5.8 liters. It is 5.8 liters. Are you able to follow this? It is 5.8 liters. Okay, is that clear? Okay, so I have told you 2 important things in this description. One is called, just a minute. Yes, one is called as the residual volume, which is number 1. Number 2 is the total lung capacity. Very good, Dr. Monshak. That is correct. Okay, this total lung capacity. Okay, fine. Are you able to follow this? Okay, fine. Now, what is the difference between the 1 and 2? What is the difference between 1 and 2? I'm asking, what is this area between 1 and 2? We have already written that. What is that? It is nothing but FVC. So, forced vital capacity. How it is calculated? FVC is the difference between 1 and 2. What is the difference? It is 5.8 minus 1.2. So, how much it is? It is 4.6 liters. So, you can just remember forced vital capacity FVC is equal to 4.6 liters. Is that clear? It is 4.6 liters. Okay. So three things I have told you: residual volume, total lung capacity, and forced vital capacity. I hope you can understand what is forced vital capacity. We have already discussed that. It is the amount of total air expired forcefully after a deep inspiration. That is what is called forced vital capacity. So three important numbers I've told you to remember: residual volume 1.2 liters, total lung capacity 5.8 liters, and forced vital capacity 4.6 liters. Are you able to follow this? Right? Clear. So now going back to the okay, I will not go back. I'll just write this here and then I will go back. Okay, right. So look at this. See, whatever we have discussed till now is the normal flow volume curve. Look at the one below. Look at the one below. What is that? It is written pathological condition. What are the two types of pathological lung disorders I told you? One is called obstructive lung disease. Another one is called restrictive lung disease. The one on the left side is the obstructive lung disease curve. Please write it. You can see that it's already written. It is the obstructive lung disease curve. The one on the right side will be the restrictive lung disease curve. It will be the restrictive lung disease curve. One on the right side. Can you see that? One on the right side. Okay, fine. Okay, fine. Now, what is your understanding from this picture on the left side, which is for obstructive lung disease? Very simple question. How is the curve being shifted? To the left side or to the right side? See, the one in the black color is normal. Okay, there is a normal flow volume curve. How it is shifted for the obstructive lung disease? Can you see that red color? How it is shifted? It is shifted like this. What is that? It is shifted to the left side. Can you see that? Very clearly it is written. Okay, very clearly it is drawn. There is a shift to left side. Please remember, there is a shift to left. Can you see that? There is a shift to the left side. And for the other one, that is a restrictive lung disease. Can you see how the curve shifted? See here, it is to the which side? Right side. It is being shifted. So please write that. It is shift to the right side. Shift to the right side. Can you see that? Shift to right. So that is what it is. Okay, shift to the right side for restrictive lung disease. I hope you're able to follow this. Obstructive lung disease, the shift to the left side, and restrictive lung disease, the shift to the right side. Easy way to remember is R for R. What is that? Restrictive lung disease, the shift is to the right. So automatically you can remember obstructive will be to the left side. This is a simple way to remember. I hope you can follow this. Okay, right. Clear? Okay. Fine. Now look at the some finer details. Okay, some more finer details for obstructive lung disease. I told you the curve is shifted to the left side. See, we are concentrating on this one. That is the obstructive lung disease, where the curve is shifted to the left side. Comment on what is happening to the residual volume. Simple question. What is happening to the residual volume? See, you just remember the volumes like this. It was like this: 1, 2, 3, 4, 5, 6 liters. Now comment. If it is shifted to the left side, what is happening to the volume? The volume is, see, initially it was 1.2 liters, correct? Now look at what is happening here in case of obstructive lung disease. It is something between 2 and 3. What is the meaning? Is it increased or decreased? It is definitely increased. The residual volume is increased. Okay. Very simple. It makes a logical thinking also. What is a logical thinking? Whenever the, say, obstruction means what? Obstruction to the flow of air outside. So what happened? All the air is remaining inside. So obviously residual volume is increased. Okay. Residual volume is the volume of air at the end of maximal expiration. Correct? Just now I told you that obstructive lung disease means the amount of air cannot be expelled outside properly. So everything remains inside the lungs only. So residual lung volume is increased. Very, very simple. Okay, residual volume is increased. I hope all of you are able to follow this, right? So RV is increased. That's what you need to remember. Next, comment about this one. What is this point which I am marking? It is a point or the volume at the end of maximal inspiration. What is happening? Yes, it is total lung capacity, TLC, total lung capacity. What is happening to the total lung capacity, which is going more than 6 liters? Obviously, it is also increased. Can you see? Total lung capacity is also increased. Okay, right. Then, what is the third point which I am marking? Comment on this point. What is this point? It is the peak point at the time of expiration, which is peak expiratory flow rate, PEFR. What is happening to the PEFR? Very simple. Initially, the PEFR was here in a normal curve, but here it has come below. So what is happening? Peak expiratory flow rate is decreased. Can you see that? Peak expiratory flow rate is decreased. Are you able to follow this? So three important things I have told you. What is that? Residual volume is increased. Total lung capacity is increased. And third, peak expiratory flow rate is decreased. That's what you have understood for an obstructive lung disease. Okay, right. Now let's move on to the right side. What is that? Right side is here. This one. I told you in restrictive lung disease, the curve is shifted to the right side. So now quickly tell me this one. What is this point? Yes, residual volume. What is happening to the residual volume? It is coming to the right side, means it is decreased, right? It is decreased. Can you see that it is decreased? And it makes logical sense also. What is the logical sense? See, restriction means restriction to the amount of air coming into the lungs, correct? Amount of air entering into the lung itself is decreased. So do you expect the amount of air to be remaining inside the lungs to be increased or decreased? Obviously, it will be decreased. So that is why the residual volume is also decreased. Very, very simple, right? Okay. Then what is this point? What is this point? It is a point of what? It is a point of what? TLC. What is the total lung capacity? Again, revise what is total lung capacity? It is the amount of air entering into the lungs after a forceful inspiration. That is what's called total lung capacity. What did I tell you? In restricted lung disease, the amount of air entering into the lung itself is decreased. Okay, very simple. So what should happen to the total lung capacity? That also should be decreased. So that is why you can see the curve shifted to the right side. Right side means the total lung capacity is decreased. Can you see that? TLC is decreased. Very, very simple. Third one, this one. What is this one? This is the peak expiratory flow rate. Again, you can see PEFR. What is happening to the PEFR? PEFR is decreased. Can you see that? Compared to the normal value. This is the normal value of PEFR. What is happening in restricted lung disease? It has come below. So PEFR is decreased. Are you able to follow this, right? So all the values have decreased. TLC is decreased, residual volume is decreased, as well as peak expiratory flow rate is also decreased. Okay, that's what you need to remember. I hope you're able to follow till this point of time. Everyone able to follow till this point of time? Please let me know if there are any doubts. Please let me know if there are any doubts. Is that clear, doctors? Okay, fine. So I think, yes. Okay, so that part is clear. So we will move on to the next one. Okay, very good. Okay, now take the previous page. Please take the previous page. This one. Now fill for yourself. Okay. If you have understood whatever we have discussed, you can fill all these three things right now itself. Please fill all these three things right now. These three things. Please fill it up quickly. Based on whatever we have discussed, please fill it up quickly. Okay, so quickly write it. What will happen to PEFR in obstructive lung disease? It will be decreased. Okay, it would be decreased without any doubt. It would be decreased. What happens to total lung capacity in case of obstructive lung disease? I told you it is increased. Residual volume, again, it is increased. Can you see that? Residual volume is again increased. Whereas restricted lung disease, what did I tell you? Everything is decreased. Okay, everything is decreased. Can you see that? Everything is decreased in case of restricted lung disease. You can just remember like this. Everything is reduced in case of restrictive lung disease. Okay, reduced. R for reduced and R for restrictive lung disease. Okay, like that you can remember. Okay, fine. Now there is only one thing which I have not told you till now, which is called DLCO. You can please write what is the meaning of this. See, it will be a little difficult right now because in your physiology classes they're going to discuss that. At the time you can learn about this in detail. I will not be discussing it anymore. Just I will tell you the name and the finding. That's all. DLCO refers to diffusion capacity. That's what it is. D for diffusion capacity of the lungs. Diffusion capacity of the lungs for, what does the CO stand for? Any guesses? What does the CO stand for? Carbon monoxide. Carbon monoxide. That is what is CO, carbon monoxide. Okay. This is the diffusion capacity of the lungs for carbon monoxide. Okay. I just want you to know some values only. That's all. I'm not going to discuss it in detail. Just writing the values and leaving it here because in physiology they will take it in a little detail. That time you can learn. I'm just going to write the values only. It will be normal in case of this particular obstructive lung disease, and it would be decreased in case of restrictive lung disease. That is the point. Okay, it would be a decrease in case of restrictive lung disease. So these are the differences between obstructive and restrictive lung diseases. Just make a note of it. This is more than enough for your exams. Okay. Usually in your exams, they ask you a question about anything like restrictive obstructive lung disease. They focus on all these points. Okay, something like a case scenario may be given. That is fine. However, they will also write one of these points in the lung function testing, which will give you a clue as to how they differentiate between obstructive and restrictive lung disease. That is what I want you to remember. Now, some examples of this two type of lung diseases, obstructive and restrictive lung disease. Can you see some examples I have written? Asthma. Okay, very, very important example of obstructive lung disease. Okay, what happens in asthma? In asthma, what happens? There is a narrowing of the bronchus, right? So normal bronchus is like this. What happens in asthma? The bronchus becomes little narrowed. That is what we call bronchoconstriction. Okay, so this is also an obstructive lung disease, correct? because the airway has become narrow. So it's an obstructive lung disease. That is what it is. COPD, we are going to discuss that as a first topic only. There are two examples in COPD. Any of you know that examples? One is called emphysema. Another one is called chronic bronchitis. We are going to study that in detail. At the time, I will tell you. And there are a few more examples also, like bronchitis, bronchiolitis, and all. But two most important examples are asthma and COPD. They are called as the prototype disorders for obstructive lung disease, which you should know. Okay, they're called prototype disorders for obstructive lung disease. Okay, fine. So just make a note of it. These are two examples of obstructive lung diseases. Okay. Then we have restrictive lung disease. What is the meaning of restrictive lung disease? I told you there is a restriction to the flow of the air coming inside the lungs. That is what's called restrictive lung disease. Okay, this could be a problem inside the lung itself. We call it as parenchymal lung problem, or it could be extraparenchymal. Extraparenchymal means outside the lungs. For example, the chest wall. Can you see something I've written? Chest wall disorders or neuromuscular disorders. What does it mean? The muscles in the chest are not functioning properly. That is why they are not able to expand properly. That is what is called neuromuscular disorders. Okay, so it can be problem inside the lungs, or it could be problems outside the lung, which is restricting the air entering into the lungs. And for your exams, you should know this only. What is that? Interstitial lung disorders, which are the best examples for restrictive lung disease. Okay, which are the best example for restrictive lung disease. Okay, so three examples you can remember for your exams. For obstructive lung disease, it is two. What are they? Asthma and COPD. And for restrictive lung disease, please make a note of interstitial lung disorders. Okay, these are all things which we are going to discuss in detail. But what I am trying to tell you is a basic introduction to all of these sections. Okay, so in this part of discussion, the main thing is regarding how to differentiate between obstructive and restrictive lung disease. And this one particular table is something which is very, very important. Okay, I hope all of you have understood this. And whenever I'm going to discuss about any further lung diseases, I will straight away tell you FEC is decreased, FEV1 is increased, something like that. I would be telling you. You should be immediately able to get back to this table and should be able to recollect it. So I hope you're able to follow all of these things. Is there any doubt till now? Everyone? Are you sure about this? Are you sure about this particular table of differences? Number one. Number two, will you be able to pick up this particular graphs which whenever they are given in your exam? I think last year the exam question was related to one of these graphs. They have put up the graph itself and they asked you what type of lung disease are you dealing in this particular patient like that. So I hope these two things are clear. Okay, if it is clear, I'm going to go to the first important lung disease, which will be about the COPD. What is that? Chronic obstructive pulmonary disease. Okay, that will be the first discussion. Okay, chronic obstructive pulmonary diseases. Okay, let's get started. Fine. Okay, fine. Okay, nice. So let us start with the names. Okay, emphysema and one more is chronic obstructive and chronic bronchitis. These are two examples of chronic obstructive pulmonary disease. Okay, doctor. Fine. Now, first point to be noted is that these are irreversible conditions. Very, very important. These are irreversible conditions. And these are conditions which are occurring in the adults. Okay, that is why I'm discussing under the medicine section. So once this condition occurs, okay, there is very, very less likely that the patient is going to improve. Except in the very early stages, okay, there is some hope for recovery. But generally, these are very dangerous conditions and they are obstructive lung diseases which are irreversible in nature. That is the point I wanted you to remember. These are all irreversible conditions. Okay, fine. And let us look at the terms, okay, in great detail. First, I want you to remember why some patients are developing chronic obstructive pulmonary disease. Okay, right? As the word is already written, the main feature is what? Airflow limitation. That is what we call it as the obstruction, and that is why they are considered under obstructive lung disease. Okay, right, fine. Now, why do you think some patients are developing this COPD? Why do you think some patients are developing COPD? What are the risk factors for COPD to develop? Please remember, in case of respiratory disorders, okay, whether it is COPD, lung cancer, bronchiolitis, any disease which we are going to discuss about, or even interstitial lung disease also, one important association will be for what? What is something which directly damages your respiratory tract? It is the smoking. It is the smoking. Very, very important. It is number one, the smoking. Okay, right? That is what will be damaging for the respiratory tract in most of the respiratory disorders. Okay. And it is not like one-time smoking. I am talking about smoking for over a long period of time. So whenever the question starts about COPD and all, they will give you a history like this. It's a long-term smoker or a chronic smoker. Like that only the question will start. Smoking is the number one risk factor. Okay, right? In your pathology classes, you will learn about the dangerous effects of smoking. At the time, they will tell you something like chemical substances present in the smoke, like tar and all, which can damage your respiratory tract. That is why we say smoking has a lot of association for chronic obstructive pulmonary disease. And you will see later also when we discuss about the management of COPD. First thing I will tell is smoking cessation. That is what I want you to remember. Okay, smoking cessation means the patient should stop smoking, because at any point of time he may be a chronic smoker. That's okay, but if he stops smoking, it is found out that it will prolong his lifespan. That is what it is. Okay, so smoking is something which is very dangerous and should be a part of treatment for all patients with COPD, that they should stop smoking. That is the first thing. Second thing is the air pollution, okay, which we are all aware of, right? Lot of pollution. Once you step out of your home, it is full of pollution only. Okay, dust, smoke, okay, everything is polluting the air. We all know about it. And over a long period of time, that smoke exposure itself can contribute to development of COPD. That is the number 2 factor. Any other factor you know? Any other factor you know? Third important factor is the genetic factor. Genetic factor, which I want you to know about. Any of you aware of this genetic factor? Any of you aware of this genetic factors? Any comments about any genetic factors? Any comments about this? Okay, it's something called alpha 1 AT deficiency. Okay, it's a special condition, doctors. Alpha 1 antitrypsin deficiency. AT stands for antitrypsin. Okay. Any of you heard about this alpha 1 antitrypsin? Any comments? Anybody? Any of you heard about this alpha 1 antitrypsin? Any of you know about this alpha 1 antitrypsin? Okay. Now, let me put it like this. Alpha 1 antitrypsin is something. Okay, I will just write. Alpha 1 antitrypsin is something which will protect elastic fibers in the respiratory tract. Okay, I hope all of you know about the role of this elastic fibers. Okay, I hope all of you know about the role of elastic fibers. Now, this elastic fibers are something which contributes to a property called recoiling. Okay, I hope all of you know about this recoiling. See, what happens is whenever we breathe, our lungs will expand, or in other words, the respiratory tract will expand like this. Then during expiration, it will constrict, right? It will constrict. This constricting is what we call it as recoiling, and that recoiling is due to the elastic fibers which are present in the respiratory tract. Okay, so basically, what is the role of elastic fibers? To help in recoiling, mean during expiration, it will try to narrow the airway so that all the air goes outside easily. That is the point to be noted. Now, alpha 1 antitrypsin normally protects the elastic fibers. Okay, please make a note of this. Okay, now whenever there is alpha 1 antitrypsin deficiency, what is going to happen? These elastic fibers will be damaged. Okay, these elastic fibers will not be protected, or in other words, they will be damaged by something called elastasis. Okay, there will be something called elastasis. What is the meaning of elastase? Elastase is something like an enzyme which will destroy the elastic fibers. Normally, it is not going to occur because alpha 1 antitrypsin is protecting all our elastic fibers. But when alpha 1 antitrypsin is deficient, what will happen? The elastic fibers will be damaged by the elastasis, and that will contribute to COPD. Okay, so please remember, in alpha 1 antitrypsin, what happens is there will be damage to the elastic fibers by enzymes called elastases. Are you able to follow this? There will be damage to elastic fibers by something called elastases. So what happens? There will be no recoil. There will be no recoil, and this would contribute to the lung damage. Okay, right. So please write this quickly. I will explain it one more time. Please write this quickly, and I will explain it one more time. Okay, now I will explain it. Very simple. Normally, in our respiratory tract, like the trachea, bronchus, bronchioles, alveoli, everywhere there is elastic fibers, which will contribute to recoiling. What is the meaning of recoiling? After initial expansion, it will contribute to limitation. That means the constriction. That is what we call it as elastic recoiling, which is with the help of elastic fibers. And all the elastic fibers in our body are protected by alpha 1 antitrypsin. When alpha 1 antitrypsin becomes deficient, there is no protection for these elastic fibers, and they will be damaged by the enzymes called elastases. And that damaged elastic fibers can no longer help in recoiling, and that would contribute to lung disease. I hope you're able to follow this. Is that clear? Okay. And this alpha 1 antitrypsin deficiency It's a condition which is inherited as AR. I hope all of you know what is the meaning of AR. AR means autosomal recessive disorder. It is an autosomal recessive disorder. Please make a note of it. Okay, right. These are the important risk factors for development of COPD, chronic obstructive pulmonary disease. I hope you're able to follow this. Clear? Okay. Now let us look at the pathogenesis of all these COPDs. Okay, right. So what is going to happen? There will be risk factors. That is what I told you, like in the form of smoking, or in the form of dust exposure, or in the form of alpha-1 antitrypsin deficiency, anything like that, there will be a risk factor. Okay, and this risk factors, all these risk factors will contribute to chronic inflammation. All the risk factors will contribute to chronic inflammation of the airways. I hope you're able to follow this. All the risk factors. Think like a typical example of smoking will lead to chronic inflammation of the airways. Is your general pathology classes taken, doctors? Is your general pathology classes taken? General pathology classes. Okay, in general pathology, they will teach you like this. What is that? Whenever there's a chronic inflammation going on inside the body, there will also be a repair process which will be going on. There will also be a repair process. I hope you're able to follow this. There will also be a repair process. But the point is, this is like a continuous inflammation. So do you expect the repair process to be working properly? Repair process will occur, but the point to be noted is it will be an irregular repair process. That is the point. Why? Because the inflammation is continuously going on. The body will try to make it correct, but because of continuous inflammation, it cannot make it fully correct. So that is what I'm trying to say. Repair will occur, but that repair will be in the form of irregular repair. And this is where the damage to the airways will start. This is where the damage to the airways will start. Okay. And depending on what part of the airway is getting damaged, you can get two different types of COPDs. For example, see, I will just try to categorize this airways into two categories. One is called as a large airway. Large airway. Large airway, I mean like what? Something like the bronchus. Okay, the bronchus. That is what I'm talking about, large airway. Or it could be like small airways. What is that small part of airway I'm talking about? I am talking about is the, what is that? Any of you know what is the meaning of this acinus? Any comment? What is this acinus? Anybody can comment about this? What is the meaning of acinus? Any comments? 1 minute. Okay, any comments? Acinus means? What is the meaning of acinus? Okay, see, doctors, see, this is the bronchus. Imagine this is the bronchus. This is the bronchus. That bronchus will divide into bronchioles. I think all of you know about this. I'm just drawing the bronchioles like this. What do the bronchioles divide into? The bronchioles further divide into smaller division. Let us take this division. It's called respiratory bronchioles. The respiratory bronchiole will have these ducts like this, and these ducts will end in the alveoli. I hope you're able to follow this. Okay, this is the branching of the respiratory tract. You just remember like this in a simple way: bronchus, followed by the bronchioles. Finally, we have the respiratory bronchioles also, and respiratory bronchioles following that you will have the alveolar duct. And what is the last part? The last part is the alveolus. This is the respiratory bronchiole I'm talking about. Okay, now can anybody comment what is called acinus? What is called acinus? What is called as acinus? All these areas. What are the areas which I'm marking? Respiratory bronchiole, alveolus, and alveolar duct. This is what we call as a acinus. This is what we call acinus. Please make a note of this. This is what we call it as the acinus. Now, when that part of the airway is damaged, we call it as a small airway damage. When bronchus itself is damaged, it's called large airway damage. Are you able to understand what I'm trying to say? So remember, depending on what part of the airway is damaged, you will have different set of manifestation. That is what I'm trying to explain it to you. Is that clear, doctors? Okay. First, let us see what is the large airway damage called as. I told you what is the area which is damaged. It is the bronchus, and the name of this condition is called chronic bronchitis. The name of this condition is called chronic bronchitis. Okay, the name of this condition is called chronic bronchitis. I hope you're able to follow. This is called chronic bronchitis. Simply inflammation of the bronchus over a long period of time. That's why it's called chronic bronchitis. Are you able to follow this? Okay, right. And always remember itis. What is the meaning of itis? Itis means inflammation. Itis means inflammation. Okay, what is going to happen? As a part of inflammation, two things will occur. One is edema of the airway will occur. Second thing, there will be irritation of the glands in that area. There will be irritation of glands in that particular area. I think all of you know our respiratory tract has got a lot of mucus secreting glands. Think like all those glands will become irritated. So what is going to happen? Think like this. This is the trachea which I'm drawing, and this is the bronchus which I'm drawing now. Okay. What is getting affected? It is the bronchus which is getting affected. And due to the edema, you think what is going to happen? There will be a lot of edema. Think about this as the edema which I'm drawing here. Can you see this? This is the edema which I'm talking about in the airway. And can you see what is happening because of edema in that particular part of the airway? What has become? The airway is normally like this, and due to edema, what it has become? It has become little narrow. Can you see that? It has become little narrow like this. Are you able to follow this? Narrowing of the airway is present due to the edema part. Due to the edema, the airway has become narrow. Fine. Second thing, the glands are becoming irritated. So when the glands are becoming irritated, what is going to happen? A lot of secretions will be produced. So a lot of mucus will be produced. I'm writing mucus plus means a lot of mucus is getting produced. So two things are happening in chronic bronchitis. What is that? One, the air column is becoming narrow. Second, lot of mucus is getting produced. Are you able to follow this? Now look at this picture. This is the picture of bronchitis. Can you see what is happening there? The air column has become narrow. Can you see that all these areas, what are they representing? All these areas are representing the edema. Are you able to follow this? And second thing, it is a mucus which is also coming out from the airway. Can you see that? So in chronic bronchitis, the air column becomes narrow and it is filled with lots and lots of mucus. I hope you are able to follow this. This is the basic pathophysiology of chronic bronchitis, where the air column becomes narrow, number one. Number two, lot of secretions or mucus is present inside the bronchus. This is what is the basic pathogenesis of chronic bronchitis. I hope you're able to follow this. Are you able to follow this? Okay, so one part is over. Now let us move on to the other part. The other part will be about small airway damage. Okay, small airway means what? Acinus is getting damaged. That is what I was telling you. What is the main role of the acinus? What is the main role of the acinus? Okay, in your physiology, you will learn that acinus is the main part of the airway which actually takes part in gas exchange. Okay, which actually takes part in gas exchange. And acinus is composed of what? I told you, every part of the airway is composed of what? It's composed of elastic fibers. So can I write it like this? Whenever there is a damage to the acinus, what will be damaged? There will be a damage to elastic fibers in that particular part of the airway. There will be damage to the elastic fibers in that part of the airway. And whenever elastic fibers are damaged, what is the problem I told you? I have told you that before itself. What is happening? There will be no recoil. Can you see that? Whenever the elastic fibers are getting damaged, there is no recoil. So here also I'm going to write there is no recoil. So now you can tell me if there is no recoil which is happening, what will happen to the affected area? Think about the alveolus. In alveoli, there is elastic fiber. That elastic fiber is getting damaged. You tell me what is going to happen. Elastic fibers contribute to what? See what happens when the air comes in, the alveoli expands like this. Okay. And when air goes out, what will happen? The alveoli should shrink like this. And this shrinking is what we call it as recoil property. And I am saying here there is no recoil happening. Whenever there is no recoil happening, what is happening? The alveoli will become expanded like this, but will it shrink again? It won't shrink again. It will remain in the expanded place like this only. So if you look at the normal alveoli, think like this. This would be the normal alveoli. Think like this. This would be the normal alveoli. How will the alveoli look in this particular condition? Here the alveoli will become enlarged like this. Or you can understand, the alveoli is becoming enlarged like this. Why it is enlarged? Because of no recoil. Because of no recoil. Yes, because of no recoil, the alveoli is getting enlarged like this. Okay, right? So this is also called as hyperinflation. Too much expansion. Can you see that? Hyperinflation. And any idea what is the name of this condition? What is the name of this condition where the alveoli is becoming so hugely dilated like this? Yes, it is called as emphysema. This is called emphysema. Are you able to follow this? Now look at this picture. Look at this picture. Can you see what I have put up? The alveoli is becoming so hugely dilated. This is what we call it as a emphysematous condition. Okay, this is what we call it as a emphysematous condition. What is the reason for emphysema? It is due to damage of the elastic fibers that the airway becomes completely dilated like this, and this is due to no recoil property. That is what it is. Okay. So again, revising the full pathogenesis part, whichever I have discussed in this point of time. What are the things I told you? There would be something like risk factors. Okay, there would be something like risk factors. Important risk factor you all have to remember is smoking. So think like this: you have a chronic smoker, and due to the smoke itself, his airways are becoming chronically inflamed. Okay, right? And chronic inflammation is the one which is going to result in these problems. And the chronic inflammation, if it affects the large airway, it is going to result in chronic bronchitis. If it affects the small airway, it is going to result in emphysema. What are the main features in the large airway or chronic bronchitis? Two things. What are the two things? One is the edema, which is causing narrowing of the bronchus. Number two, lot of secretions or mucus is produced in the bronchus. These are the two features of chronic bronchitis. Then we move on to the other part. What is the other part? Emphysema. In emphysema, what is happening? There is damage to the elastic fibers. So the acinus or the alveoli becomes irreversibly dilated. Irreversibly becomes dilated. And that irreversibly dilated alveoli is what we call it as an emphysematous airway. And what is the other name for this dilatation? It is also called hyperinflation. Are you able to follow this? Whatever I have told you till now are something like basic pathogenesis of the COPD. I hope you are able to follow till this point of time. Is everybody able to follow this? Any doubts in this? You please let me know. Any doubts in this? Any doubts till now, doctors, regarding the pathogenesis of COPD? Pathogenesis of COPD. Is there any doubt in this? Fine. Okay, I hope it is clear for every one of you. So we will move on to the next part, where I'm going to discuss about types and some clinical features of each of these conditions. Okay, let us start with emphysema. Take from the next page. Emphysema. I am going to discuss about the clinical aspects and some types of emphysema also. Okay, fine. Good. Okay, so let us get started. First is about the types of emphysema. This is purely a pathology question. Okay, doctors. Okay, this is purely a pathology question. Types of emphysema. See, okay, fine. What did I tell you? Emphysema means what is the condition? It's a condition of irreversible dilatation of the acinus. Okay, it's a condition of irreversible dilatation of acinus. Okay, it's an irreversible dilatation of the acinus. That is what I told you. That is what is called emphysema. And depending on which part of the acinus is getting affected, we have different types of emphysema. Okay, I will draw the first one. You try to tell me what is the type. Okay, I will just draw the first one. Okay, which is the most common type. I'm just drawing like this. Okay. Any comments on first this one? Any comments on this one? Okay, get your orientation correct. This is the respiratory bronchiole. This is the respiratory bronchiole. I'm just drawing the acinus only. This is the respiratory duct, okay, or what we call it as the alveolar duct. And this is, of course, the alveoli. So now you tell me which part is dilated. Which part is dilated? Is it the full acinus which is dilated? Is it the full acinus which is dilated? Not at all. It is not at all. Which part is actually dilated? This is the part which is actually dilated. What is this part? It is a respiratory bronchiole only is dilated. So can I put it like this? The central part of the acinus is only dilated. The central part of the acinus is only dilated. Call it as a centriacinar type. This is called as a centriacinar type, which is the type which is commonly seen in the smokers. This is the type which is commonly seen in the smokers. And this is usually involving the upper lobe. Please remember this. Usually it involves the upper lobes of the lungs. Okay, so this is called centriacinar type, which is common in smokers and usually involving the upper lobes. This is the number one type called centriacinar type. Second type, which I'm going to draw like this, you can tell me like this. Okay, what I'm trying to draw? I'm trying to draw emphysema only, but can you see the entire acinus is getting dilated? Can you see the full acinus, respiratory bronchiole, alveolar duct, alveoli, everything is getting dilated, correct? This is what we call it as the, every part of the acinus is affected. So what is the name I will use? I will use it as a pan-acinar type. I will use it as pan-acinar type. Pan-acinar means every part of the alveoli is getting dilated. Very simple. Every part of the acinus is getting dilated. So it's called pan-acinar type. This is something which is seen in the genetic disorder. What is that? Alpha-1 antitrypsin deficiency. That condition is characterized by pan-acinar type. This is an important MCQ question. I'm marking it like a Q. It is an MCQ question which has been asked previously. And this is something which affects the lower lobe of the lungs. This is something which affects the lower lobe of the lungs. These are all facts which you should just know about it. Okay, right. So this is number 2 type. Number 3 type. Okay, comment on this one. What is this? Now I am focusing on this area only. What is this area? What is this area? It is the distal part of the sinus. Can you see that? Only the last, okay, sorry. Only the last part of the sinus. Can you see the last part? This is the distal part. Only the alveoli is getting affected. So what do you call this type? This type is called distal acinar type. This is distal acinar type. This is also something which is usually encountered in smokers only. This is also something encountered in smokers. Any other name for this type pathologically? Any other name for this type pathologically? It is something which is, see, what is the separation between the two alveoli called as? What is the separation between the two alveoli called as? Any idea? Separation between two alveoli. They are called as septum. Okay, they are called as septum. So think like this. This area is what we call it as a septum. So this is something which is near to the septum, correct? Something near to the septum. So I will call it as another name for this is also called paraseptal type. It's also called paraseptal. Always remember this. Para means near to the septum. So it's called paraseptal type. This is called distal acinar type. Please make a note of it. It's also called distal acinar type. Okay, fine. The last one, I am not going to draw anything because it is something like the end stage. It is something like the end stage of any type of emphysema. That is the last stage of any type of emphysema, which is characterized by fibrosis, or scars. I'm writing scarring in the sinus. Fibrosis or scarring in the sinus. This is called as the irregular type. This is called as a irregular type. This is called as a irregular type. Okay, it is called as an irregular type. Means what I'm trying to say, it is like the end stage. See, initially the patient can have centriacinar, panacinar, or distal acinar. Towards the end, it will move on to the irregular type. So what I'm trying to say, you don't need to mark it. To begin with, it can be centriacinar type. So last stage would be irregular type. Same thing. To begin with, it can be panacinar type. Last stage would be irregular type. Distal acinar to begin with, last stage would be irregular type. So what I'm trying to say, whenever irregular type occurs, how do you think will be the patient's condition? It is almost like the end stage for that particular patient also. So irregular type is associated with very, very high chance of death. So when do you encounter this condition? Is it in a live patient or after death only you will be seeing this? It is after death only. Whenever you do the post-mortem and all, you encounter this irregular condition. So this by itself is a question. Irregular type, okay, this is a question. Irregular type is the most common type. Okay, it is the most common type seen in most common type which you encounter in post-mortem specimens. Or in histology, you will encounter this type of specimens. That is what I want you to remember. So imagine like this. Whenever the irregular type develops, there is a high chance that the patient will die. And after death of the patient, when you do the postmortem, that time only you encounter this type of cases. I hope you are able to follow this, right? Yes, this is the most common type in postmortem or in histology. Now there can be one more question. What is that? What is the clinically common type then? Any idea which is the clinically most common type? Which is the clinically most common type? The clinically most common type is centriacinar type. The most common type clinically, it is centriacinar type. This is an important MCQ question. Okay, this is an important MCQ question. Don't forget this. This is important MCQ question. Please don't forget. Is that clear? Right? Are you able to follow this? Everybody able to follow this? So these are the 4 types I have told you. Centriacinar, panacinar, distal acinar, and irregular type. Overall, most common type clinically is centriacinar type, which is commonly encountered in the smokers. Then if you talk about a patient who has died with the COPD or emphysema, what is the common type in him? There it is an irregular type because irregular type is almost always associated with death in the patient. That is what I want you to remember. Is that clear? So irregular type is the end type of COPD or emphysema. That's all. I hope you're able to follow this. This is about the pathology of emphysema I have told you. Now I'm moving on to the clinical features. Okay. See, what did I tell you? It's an irreversible dilatation of the sinus. Correct? It's an irreversible dilatation of the sinus. So think like this. The alveoli is so hugely dilated like this. When the alveoli is so hugely dilated, what is going to happen? What is going to happen? So much of air will be there inside the acinus itself. Are you able to understand this? So much of air will be inside the acinus itself, or so much of air will remain inside the lung itself without being expelled out. Remember, this is obstructive lung disease. So what is the point? Air will not be going out frequently. So where is all the air collecting? All the air is collecting inside the acinus itself. Are you able to follow this? All the air is collecting inside the acinus itself. So how do you think? So what do you think will be the amount of air inside the lungs? It will be too much of air inside the lungs. So all the clinical features result from too much of air accumulating inside the lung itself. This is what we call it as air trapping. This is called as air trapping. Please make a note of this. This is called as air trapping. Don't forget this. This is called air trapping. This gives rise to all the features which are encountering in case of this particular condition. Okay. So if you look at the patient itself, the chest, do you know how the chest will appear? So much of air is there inside the lungs. So the chest will appear too much expanded like this. The chest will appear too much expanded. Any idea what is the name of this chest called? Too much expanded chest called? It is called as any names? Any of you know any names? Okay, it is called as a barrel-shaped chest. It's called as a barrel-shaped chest. I think all of you know barrel, right? It is something like a very distended part or distended vessel. Something like that. Too much of air is there inside the lungs, and this is what we call as a barrel-shaped chest. Okay, and of course, because the air is not going out freely, the patient will also have breathing difficulty. Breathing difficulty. Any name for this breathing difficulty? It's also called dyspnea. It's also called as a dyspnea. It's also called as, yes, correct, barrel chest only. It's also called dyspnea. So chest is barrel shaped, and next thing, the patient will have breathing difficulty also. Okay, fine. And can anybody comment on the X-ray, doctor? Can anybody comment on the X-ray? Comment on this X-ray. This is X-ray picture. Any comments on this? Okay, think like this. The normal lung field should be something like this only. Normal lung field should be something like this. Here, what is happening? Here, what is happening, doctor? Here, what is happening? Can you see the lung fields are too much expanded like this? The lung fields are too much expanded. Can you see that? The lung fields are so much expanded like this. Can you see that? Why it is so much expanded? It's all due to what? It's all due to air trapping only. The lung field is so much expanded like this. Any idea what do you call this finding on the X-ray? Any name for this finding on the X-ray? Any comments? It is called bilateral. Both sides it is present, right? It's called as a bilateral hyperinflation. Please don't forget this. It's called as bilateral hyperinflation. Don't forget this. This is important. It is called bilateral hyperinflation. Please don't forget this one. Okay, clear? This is too much expanded lungs. So patient will have breathing difficulty. Patient will have a barrel-shaped chest. Patient also on X-ray will have a bilateral hyperinflation. Okay, right? Hyperinflation. Okay. Now, one thing which is happening. What is happening here? What is happening? Any idea? See, air is trapped inside the lungs. Are you able to follow this? Air is getting trapped inside the lungs. Okay, and you can also see like this. What is happening? See, when the air columns are becoming dilated like this, you just think like what I'm drawing. You don't need to draw this, but this is a picture of a expanded emphysema. You think like this. See, when the air comes inside, it should go like this. It should go like this, and then it should go outside the. Wait. It should go outside the. Alveoli, enter into the artery and enter into the body like that. But here, what is happening when it is so much dilated like this? You tell me, all the air will go into the alveoli properly? No. What will happen is the air will get collected in the spaces, in the sides like this. In the spaces like this, in the sides, it will get collected. Do you think this air will get exchanged, or this air will enter into the lungs, or this air will enter into the body? Do you think all the air which is collected in the sides will enter into the body like that? It won't enter. Or in other words, this is what we call it as what? This is what we call it as a dead space. Something like this. What is it? The air will be there in the dilated space without going into the body, or it will increase the dead space. So now, when so much of air is there going waste without entering into the body, what will happen to the oxygen level inside the patient? What will happen to the oxygen level inside the patient? Simple question. Hypoxia. Very correct. There would be hypoxia. I hope you can follow this. The patient will have hypoxia. Are you able to follow this, right? When air is not getting entered into the body, there will be hypoxia. Are you able to understand this? Correct? There will be so much of hypoxia. And whenever there is chronic hypoxia, what will happen is that there would be something like acidosis developing inside the body. I hope you can all follow this. Why acidosis will develop? Very simple question. Whenever there is hypoxia, the body will not have enough oxygen for metabolism. So what type of metabolism will occur inside the body? You will not get aerobic metabolism. You will get anaerobic metabolism. And during anaerobic metabolism, what is the substance which is produced? Lactic acid will produce, and that will result in lactic acidosis. Are you able to follow this? This would result in lactic acidosis. Are you able to follow this? This would result in lactic acidosis. And this lactic acidosis, when it affects the lungs will start breathing very fast. Or in other words, what is going to happen? Something called as hyperventilation will occur. Hyperventilation will occur. And whenever there is hyperventilation, there is too much of breathing which is happening, correct? There is too much of breathing which is happening. So hyperventilation will result in what? Too much of air being expelled out from the lungs. What is the air which comes out of the lung? Is it oxygen or carbon dioxide? It is carbon dioxide. And this is what we call it as a carbon dioxide washout. This is called as carbon dioxide washout from the lungs. Are you able to follow this? This is called as carbon dioxide washout from the lungs. I hope you're able to follow this. This is called as carbon dioxide washout from the lungs. Are you able to follow this? So two problems which are happening in a patient with emphysema. What is that? One, there is so much of oxygen which is not entering into the body and going waste inside the dilated spaces. So there is hypoxia happening. And because of hypoxia, there is acidosis. And because of acidosis, there is hyperventilation, resulting in too much of carbon dioxide getting washed out from the lungs. Are you able to understand this? Okay. And over a long period of time, this can result in a complication. What do you call this complication? Too much of low oxygen and too much of carbon dioxide washout also from the lungs. So what is going to happen? What is going to happen whenever there is hypoxia? What will happen to the level of oxygen inside the arteries? Whenever there is hypoxia, what is happening to the level of oxygen inside the arteries? Yes, of course, it is decreased. This is what I'm writing, decreased PaO2. I hope you can follow this. PaO2 refers to P for pressure, A for the artery. Arterial oxygen pressure is decreased. That is what I'm trying to tell you by decreased PaO2. Not only that, carbon dioxide is getting washed out, correct? Carbon dioxide is expelled from the lungs. So what will happen to the level of carbon dioxide in the artery? That also will be decreased. Decreased PaCO2. That is, arterial carbon dioxide is also decreased. And this complication where you have low oxygen as well as low carbon dioxide inside the body is what we call it as, what do you call this? You call it as a type 1 respiratory failure. This is called as a type 1 respiratory failure, simply called as hypoxic respiratory failure. Simply called as a hypoxic respiratory failure. This is the number one complication. I hope you're able to follow this. This is called type 1 respiratory failure or hypoxic respiratory failure, the number one complication of this emphysema. I hope you're able to follow this. Clear, doctors? Right. Number two complication is something like this. I told you there's a chronic hypoxia happening inside, correct? There's a chronic hypoxia which is happening. And due to chronic hypoxia, please remember in physiology you will learn that hypoxia will cause vasoconstriction because normally oxygen is a vasodilator. When there is low oxygen, it will result in vasoconstriction. So this is going to result in pulmonary vasoconstriction. This is going to result in pulmonary vasoconstriction. This is going to result in pulmonary vasoconstriction. So whenever there is vasoconstriction, what is going to happen? There will be increase in the pressure in the pulmonary artery, correct? Increase in the pulmonary artery pressure. Increase in the pulmonary artery pressure. Okay. And whenever there is a pulmonary artery pressure which is increased, which side of the heart pressure also should increase? Which side of the heart pressure also should increase? It should be right ventricle because the right ventricle is the one which pushes the blood into pulmonary artery. When pulmonary artery pressure increases, the right ventricular pressure also will increase. Okay, right ventricular pressure also will increase. How can the right ventricle increase its pressure? It can increase its pressure only by increasing its size, or what we call it as RVH. I hope you can understand that. What does that RVH means? Right ventricular hypertrophy. Only when the right ventricle undergoes hypertrophy, it can push the blood into pulmonary artery against a high pressure. But when the right ventricular pressure goes on increasing, do you think the heart can function properly at one stage? Not at all possible. And at one stage, it will lead on to heart failure. And at one stage, it will lead on to right-sided heart failure. Okay, it will lead on to right heart failure. Okay. What do you call this condition? What do you call this condition? In India, what do you call this condition as? Yes. Yes, it is a heart failure due to a lung problem. Are you able to understand this? It is not due to heart problem. It's a heart failure due to a lung problem. Any name for this? Anybody? What is this called? Heart failure due to a lung problem. It is called as cor pulmonale. Please make a note of this name. It is called as a cor pulmonale. Okay, right? So what is this cor pulmonale? It is something like heart failure. Cor means refers to the heart. Okay, please remember, cor refers to the heart. Pulmonale refers to a lung problem. So due to a lung problem like emphysema, the heart is failing. So this is called cor pulmonale. So two important complications I have told you for emphysema. One is type 1 respiratory failure. Number 2 is cor pulmonale. Are you able to understand this? Everybody able to understand this? Clear, everyone? Okay, very good, Dr. Neha. You got it correct. It is cor pulmonale only. Correct. Clear? Yes. So let us just quickly look at some of the important findings of emphysema. What are some of the important findings of emphysema? If you look at the patient clinically, he will have breathing difficulty and he will have a barrel chest. That means expanded chest. And also on an X-ray, he will have bilateral hyperinflation. What is the reason for this barrel chest and bilateral hyperinflation? It is simply air trapping. That is the main reason for all these problems. Okay. And whenever air gets trapped inside the lungs only, there will be hypoxia. And because of hypoxia, there will be triggering of hyperventilation and carbon dioxide washouts on the lungs. This would lead on to the first complication, which is called type 1 respiratory failure, which is characterized by hypoxia. That is a point to be noted. Number 2, chronic hypoxia can also trigger right-sided heart failure, and that is what we call it as a cor pulmonale. Are you able to understand this? Right? Okay. And there's a very classical description of this particular condition. What is that? Of this emphysema, that's a classical description. What is that? If you look at the patient, they are usually smokers. Correct? I told you, this is something which is common in the smokers. Number 1. Number 2, they are usually thin-built. They are usually thin-built. And third thing, there is no cyanosis. I'm writing minus means there is no cyanosis. That's what I'm writing. There is no cyanosis. And because of these three things, you know what you call these patients? Just like a term. It's like a simple trick to remember. Not a trick actually. It's a simple tip to remember emphysema. In India, what do you call that? They're thin-built patient, smokers, always smoking, and no cyanosis. What do you call that? It's called as a pink puffers. Pink means there is no cyanosis. Puffers means we are talking about the smoking. They're always puffing or smoking. So this condition is also called as pink puffers. Please don't forget this. It's also called as a pink puffers. That is a term which we use for this particular condition of this emphysema. I hope you're able to follow this. This is all about emphysema, which you should know for your exams. Is that clear? Everybody able to follow till this point of time? Everyone? I've just tried to describe the findings of emphysema. Everyone able to follow this, doctors? Fine. Okay, correct. Now we move on to the next condition. What is the next condition? The next condition will be about chronic bronchitis. Okay, quickly recollect. Chronic bronchitis means, what is the point I'm trying to tell you? It is something like, chronic bronchitis is what? Chronic bronchitis is a condition wherein large airways are affected. Don't forget the two important things I told you. What are the two important things in chronic bronchitis? One is edema causing narrowing of the bronchus. Second is lot of mucus is getting produced due to inflammation of the airway. This is the thing which I want you to remember. So think like this, what all the findings will be there? First one, what would be the first one? There will be a lot of mucus which is present, correct? There is a lot of mucus which is present. There is a lot of mucus which is present. And because of mucus, what is the problem? The mucus will irritate the respiratory mucosa, and lot of mucus, the patient will try to expel it out in the form of coughing. So the characteristic feature will be the patient will be presenting with recurrent cough. The patient will be presenting with recurrent cough. You know the definition of chronic. What is the meaning of chronic? Chronic is something for a long period of time. More than 3 months of coughing. This is what is the classical description. The patient will say that I am having coughing for a long period of time. Many months, at least 3 months according to definition. That is what is called chronic bronchitis. At least 3 months of cough, he will have recurrent coughing. Okay, right? And you tell me what will be the type of cough? There will be mucus coming out in the cough. So this is called as a wet cough, or also called as a productive cough. This is also called as a productive cough. Okay, wet cough or the productive cough. Are you able to follow this? Okay, too much of cough will be produced, called as a wet cough or the productive cough. Second thing, what did I tell you? If you examine the patient, what finding you will get? Think like this. This is the trachea. Sorry, this is the trachea and the bronchus. What is happening to the bronchus? I told you, it has become narrow. Quickly recollect why it has become narrow like this. This narrowing is due to what problem? It is due to edema. So now you tell me, as the air passes through this narrow bronchus, what sound do you think will be produced? When the air is passing through a narrow bronchus, what sound will be produced? Very simple question. Narrowing of the bronchus results in what sound? wheezing, stridor, crepitation. What sound you can hear? You will hear wheezing. Okay, you will hear wheezing. So the second feature will be lot of wheeze would be heard on auscultation. So two important things. One is wheezing would be heard. Second, the presenting feature will be patient having repeated cough-like episode. This is how they typically present. Okay. So now let us see what are all the problems which are going to occur. Simple thing. Okay, what are the problems which are going to occur? See, when the air column has become narrow like this, the bronchus has become narrow. What is happening to the air entering into the alveoli? That also will be less only. Can you see that? When the bronchi has become narrow, through the bronchus only the oxygen has to enter into the alveoli. So what happened when the bronchus has become narrow? The air entering into the bronchus is less, and the air entering into the alveoli also will be less. So I'm going to write it will result in less oxygen into the alveoli. Less oxygen enters into alveoli. Are you able to follow this? Less oxygen enters into alveoli. So what is going to happen? There will be severe hypoxia. Very, very important. There will be severe hypoxia. Are you able to follow this? There would be severe hypoxia. Please remember, when only very less oxygen enters into the alveoli, there will be severe hypoxia. And this severe hypoxia itself will result in the patient becoming blue. What is that? Cyanosis. The patient becoming blue. That is what is called cyanosis. Are you able to follow this? The patient will become cyanosed. Are you able to follow this? Please make a note of this. Okay. Next thing, when less air enters into the alveoli, the amount of carbon dioxide exchange also will be very, very less. Always remember this point. That always remember this point. The point is that whenever the amount of air entering into the alveoli is less, the amount of air carbon dioxide which is exchanged out of the alveoli also will be less. So what is going to happen? Less carbon dioxide is expelled through lungs. Less carbon dioxide is expelled through the lungs. Are you able to follow this? Less carbon dioxide is expelled through the lungs. When less carbon dioxide is expelled through the lungs, what is happening to the level of carbon dioxide inside the blood vessel? What is happening to the level of carbon dioxide inside the body or inside the blood vessel? It is increased. There is increased carbon dioxide in the blood vessels or in the arteries and all. There is an increased carbon dioxide because it is not getting expelled. What do you call this? You call this as what? This is what we call it as hypercarbia. This is what we call it as hypercarbia. This is what we call hypercarbia. I hope you're able to follow this. It is called hypercarbia. Please make a note of this. It is called hypercarbia. Now, because of hypercarbia, what is the problem? Because of hypercarbia, what is the problem? Any idea? Will it lead to acidosis or alkalosis? Will it lead to acidosis or alkalosis? Increased carbon dioxide. Will it lead to acidosis or alkalosis? Any comments? Previously, I told you. Okay, sorry, just a minute. Sorry, that is getting changed. Okay, you tell me what is happening. See, whenever there is too much of carbon dioxide, you just remember like this. There is an equation which I think all of you should be knowing. CO2, okay, it's carbon dioxide plus water combined to form what? H2CO3, and that H2CO3 will split up into H plus and HCO3 minus. Correct? So now you tell me what is going to happen. Very simple. Whenever there is increased levels of carbon dioxide, there will also be increased production of H plus. H plus means what? H plus means what? Acid. So this condition is going to result in respiratory acidosis. This condition is going to result in respiratory acidosis. Remember, for this condition is going to result in respiratory acidosis. That is a point which I want you to remember. And second point which I want you to know is because of hypercarbia, please remember this, the patient will have excessive sleepiness. Patient will have excessive sleep. He will be sleeping for a long period of time without doing anything else. So because of this, what is going to happen to the weight in the patient? There will be obesity. There will be overweight or obesity. Are you able to follow this? Okay, so if you look at the patient, two findings can be noted. What are the two findings which can be noted? One is cyanosis can be noted. Second thing, patient will also be obese. So that is why this condition, you know what is this called? You know what is this condition called as? It is called as blue bloatus. It is called as blue bloatus. Blue bloatus. I hope you can follow this. Blue here refers to cyanosis. Bloatus here refers to obesity. So that is why it's called as a blue bloatus. I hope you're able to follow this. Okay. So the name for chronic bronchitis is called blue bloatus because they have cyanosis and because they are also excessively obese. Are you able to follow this? They are also excessively obese. I hope you can follow this. Clear, doctor? Right? Okay. Whereas, what is the term for emphysema? I told you. It is called think buffers. This is called blue bloaters. I hope you're able to follow this. Okay, right? These patients can also develop respiratory failure. But what type of respiratory failure? Here, there are two things which you can notice. What are the two things which you can notice? One is hypoxia. Second one, they're also having hypercarbia. This type of respiratory failure is called as type 2 respiratory failure. Type 2 respiratory failure. Please don't forget this. Type 2 respiratory failure is characterized by hypercarbia, which is high levels of carbon dioxide inside the body. This is called type 2 respiratory failure. Don't forget, in emphysema, I told you type 1 respiratory failure, correct? In type 1 respiratory failure, there is only hypoxia. In fact, there was carbon dioxide washout. It is characterized by low carbon dioxide. Whereas type 2 respiratory failure, you will have high carbon dioxide. That is the point I want you to remember. Is that clear? Okay, right? So easily you can remember like this. Bronchitis, correct? Chronic bronchitis. Chronic bronchitis. You remember like this. Bronchitis, B, you remember. Bronchitis, B, you remember. B for two things you can remember. What is that? Blue as well as bloaters. B means you all know that it is a second alphabet, correct? It is a second alphabet in English. So for that you can remember type 2 respiratory failure. Type 2 respiratory failure. Are you able to follow this, right? So this is easy to remember because in emphysema, what is the type of respiratory failure I told you? It is type 1 respiratory failure. And in case of bronchitis, it is type 2 respiratory failure. Are you able to understand this, doctors? Are you able to understand this? So quickly remember the important differences. In emphysema, the patient is thin built, also has no cyanosis. So that is why it is called as pink puffer. Whereas in chronic bronchitis, the patient is obese as well as have cyanosis. So it is called as blue bloaters. That's all. Emphysema, it is type 1 respiratory failure. Bronchitis, it is type 2 respiratory failure. What is the meaning of type 1 respiratory failure? It is only hypoxia with low carbon dioxide. Whereas type 2 respiratory failure is hypoxia with high carbon dioxide. That is what I want you to remember. Is that clear, doctors? Fine. Is it clear till this point of time? Everyone are able to follow this? Because in your exam, the question will be like a clinical scenario where they will give you any combination of these findings and they will ask you what is the type of COPD in this patient. For that only you should be able to answer like this. I hope you can answer this. Everyone? Fine. So now let us move on to the last part, which will be about what? Management of this particular condition. First itself, I told you, this is an irreversible condition. You cannot reverse this. Only symptomatic management you can give for this patient. So what are the symptomatic management which can be available? What is the symptomatic management? One is, what is the main problem in all these conditions I was telling you? It was low oxygen, hypoxia. So what you can do is you can give oxygen supplementation to these patients, even from the home itself. I'm going to write home oxygen supplementation. Okay, which the patient can use it from the home itself. Or basically, you can remember this patient will be oxygen dependent. And also, please write the goal is to keep the SpO2 in the normal range. Any idea what is the normal range? We have to keep it more than 90%. That is the point. The goal is to keep SpO2 in the normal range of more than 90%. So home oxygen supplementation is something which is very important. Second thing I told you, in most of the COPDs, which condition will have a role? What is the risk factor? Smoking. So smoking cessation. Smoking cessation. Okay, right? And I told you, if you can follow these two things very meticulously, this can even decrease the mortality in the patient, meaning the patient can survive for a long period of time. Not that you can reverse this condition, but you can make the patient to survive for a long period of time. In one of your previous year questions, they asked a question like this: which of the following helps in the maximum prolongation of lifespan in a patient with COPD? Both oxygen supplementation was given in the option as well as smoking cessation was given in the option. You have to choose the best one. Which is the best one out of these two, which can prolong the life of these patients? It is home oxygen supplementation. So I'm putting 2 ticks for there because that is supposed to be the most important intervention which you can do. Oxygen supplementation in the patient will improve the lifespan of the patient over a long period of time. That is what you should remember. So the best answer to choose for that question was home O2 supplementation. Any drugs we can use for this patient? For example, a patient with bronchitis. What was the problem in bronchitis? There was narrowing of the bronchus. So what drug you can use? You can use bronchodilators. You can use bronchodilators. Correct, doctors? You can use bronchodilators. So what type of bronchodilators you can use? There are, I think in your pharmacology classes you have learned, there are 2 types of bronchodilators. One which acts in the central airway, like the trachea and bronchus. Another one which acts on the level of peripheral. You have to tell me any answers for this. Central airway or the trachea and the bronchus. What is the best example of that? central. What is the central like bronchodilator? It is anticholinergics. Any of you know some names? Anticholinergic names, centrally acting anticholinergic for dilatation effect. Ipratropium. Example would be ipratropium bromide. Ipratropium. That's what you have to remember. Anything for peripherally acting bronchodilator? This I think most of you should be knowing. Short acting beta 2 agonist. What are they? Yes, it is salbutamol. Correct? It is salbutamol. Which do you think is very helpful in a patient with bronchitis? Is it centrally acting or peripherally acting? Of course, bronchitis means what? Centrally acting bronchodilator. So, from a therapeutic point of view, central bronchodilators are very useful compared to peripherally acting bronchodilators. I hope you're able to follow this. Central more than the peripheral. That's what you need to remember. Okay. Then one more thing I want you to remember is something called exacerbations. Exacerbations are nothing but a condition where a patient is already having COPD and is having a sudden worsening of that condition. Sudden worsening. For example, you know that this patient is a patient with bronchitis, things like this. One fine day, he is suddenly coming to your emergency room saying that, doctor, I am having excessive breathing difficulty. That is what we call exacerbation. It is usually due to infections. It is usually due to respiratory infections. That is what, like, commonly due to bacterial infections like that. It is commonly due to infections with bacteria, right? Something like pneumococci, or during the seasons and all, due to influenza virus, they can have this exacerbation. So what you have to do, you have to control the infection in this patient. So for all patients who are having a respiratory infection like exacerbation and all, what you will start in the management, you should also start an antibiotic. Very, very important. You should also start antibiotic. Of course, influenza is a virus, you don't need to start antibiotic, but generally I'm saying it is due to bacteria. So what you should do, you should start antibiotic. The typical antibiotic which we start is macrolide antibiotics. Macrolide antibiotic. Any of you know any example of that macrolide antibiotic? Any example of macrolide antibiotic? Yes, example would be azithromycin. Okay, right. So just keep in mind that for a patient, this is a chronic condition. First of all, this is a chronic condition, first of all. So we cannot reverse this condition also. So all that is required is symptomatic management in the form of O2, in the form of stopping the smoking, and in the form of bronchodilatation. That's all you can do. If a patient present to the ICU, please think of an infection causing that exacerbation. And for that patient, you always have to start antibiotic. That's all. I hope the plan of management is clear. Now, this is an important MCQ question. What is that? What is the best parameter for a patient with COPD? Suppose you want to tell the prognosis in that patient, like how long he can survive, whether he is doing well or not. What is the best parameter for monitoring, for follow-up, as well as for prediction of survival? Basically, it is for prognosis. That is what I'm trying to ask the question. Which is the best parameter for that? It is FEV1. Don't forget this. It is the amount of FEV1 which will tell you about the prognosis in the patient. It's a very important MCQ question. Please don't forget this. It's a very important MCQ question. Please don't forget. Correct? It is the best parameter for prognosis in a patient with COPD. That is the point. Okay. Now, any of you have any idea about this pursed lip breathing? Any of you have any idea about this pursed lip breathing? It's something like this. I'll just take up the picture. Wait, this picture. See, this is a picture of pursed lip breathing. Can you see that? What you have to do is you have to ask the patient to inhale like 1 or 2 seconds and then slow exhalation. That is the key word here. It is a slow exhalation. Can you see that over a period of 4 seconds? And also, he should keep the lips not wide, or mouth should not be wide open. It should be like a closed mouth with the lips alone opening like a purse. That's why it's called pursed lip breathing. It's called slow exhalation. Any idea what is the slow exhalation going to do? Any idea what is the slow exhalation going to do for the patient? How do you think that is better for the patient? That is something which you're going to find out. Okay, I am going to give a break now. In that break time, you just try to find out how pursed lip breathing or the slow exhalation breathing will help in a patient with COPD. Okay, that you are going to find out. Okay, during the break time. So, okay, so that is about our first topic, which is about chronic obstructive pulmonary diseases. I hope all of you are able to follow this. I hope all of you are able to understand the pathophysiology and pathogenesis of COPDs and some clinical correlations also. These are all very important questions, and we're putting up some certain examples also towards the end of discussion, okay, where I will put it like a clinical scenario and I will ask you what is the diagnosis, whether it is bronchitis, whether it is emphysema, like that I will ask you the questions. I hope you're able to follow the discussion till this point of time. Everyone able to follow the discussion? If you have any feedbacks or comments for me, please put it up in the chat section. I will be able to see that. Okay, fine. So we will have the break now. Now the time is 11:15. We'll have a 15 minutes break. Is that okay? Can we resume at 11:30? Is that fine, daughters? Around 11:30, I will be able to, I will resume it. Okay, so the time 11:30, around 11:30, I will be resuming. Okay, done. Okay, right. Around 11:30, we'll start. Please try to see what is pursed lip breathing if you have just time. Okay, when you're having the tea or coffee at the time, just try to Google it and see what is this pursed lip breathing. Okay, fine. Okay, so I will resume after 15 minutes. So I hope everything is fine. So I was just reading your the comments also which you had sent me. I understand that you are not able to put it in chat at the time of listening to the classes. That is perfectly fine because like I also wanted to know, I mean, like how the class is going on or any feedbacks like that. So that is why I was in between asking you the question. I hope that is not an issue. You can let me know the doubts or anything like that in between the, I mean, after the class also. I'm sharing with you my Telegram number. You can ask me any doubts you have at any point of time directly in my Telegram number itself. This is my number. You can just add it and let me know your doubts at any point of time. And even when the class is going on also, suppose you are not able to understand one particular concept, you can just stop me there and ask me to repeat that particular point. Of course, the only way of communication would be in the chat section. Okay, so if anything you don't seem to actually understand it, you please stop me there. I will look into the comments and it is there in my other screen on both the sites I have. So I will repeat that particular point. And minor doubts or anything else also you need to ask, you can contact me in my Telegram. I think that would be a better way to solve those type of questions. I hope that is sorted. Fine. You don't need to comment anything on the chat section. I understood it. So I hope the class is going on well. You are able to understand the concepts. And I think the speed is also manageable because if it is a live class, I can see your faces and I can access the response. But this being an online class, I'm going at my own pace. So I hope it is comfortable for all of you. Okay, right. So we will get started with the next set of topics. Okay, the next set of topics. Before that, did you all look up this this particular thing which I had asked you just a minute regarding this pursed lip breathing? Did you all see that? Very simple concept only, that when a patient is going to have a slow breathing, it effectively tries to push us out a lot of air. Or in other words, it helps in better ventilation. That is why we always advise a patient who is having the COPD to practice this type of breathing. Like whenever you exhale, you slowly exhale. That is what we keep telling the patient because that is found to have a better impact, okay, on exhalation, okay, right, and in improving the lifestyle of this patient also, or the quality of life in this patient also. That is what. So this is what is a summary of whatever we have discussed till now. Can you see that? Very classical things. Can you see? Yes. The main thing in emphysema is the dilated alveoli. Can you see that the main thing in emphysema is the dilated alveoli? And we can see the patient is thin and not having any cyanosis. That's why they are called as a pink puffers. Can you see that? That is why they are called pink puffers. And second thing, chronic bronchitis. You can see the patient, chronic bronchitis, what is happening? The problem is in the bronchi. Can you see that? All the bronchi is filled with the mucus and it is edematous also. That is why it's called chronic bronchitis. And you can see the appearance of the patient. He is obese and he's also having cyanosis. That is why they are called as what? They are called as blue bloaters. So I hope you're able to follow this differences between the emphysema and chronic bronchitis. Two important conditions for you to know about. Even scenario-based questions are often asked in your exams. Okay, right. So with that, we move on to the next topic. The next topic will be about, and follow from the notes, will be about asthma. Okay, another important topic for the exams. So frequently asked in the exams. Nowadays, I don't see many questions, but still, it's an important topic for you to know. I will tell you what are the types of questions being asked nowadays in the exams, and also I will highlight upon certain points which are important for management aspect also. Okay, right. Fine. So let us get started with the asthma topic. We all know that asthma is a condition which is on exposure to allergen it develops. Okay, usually on exposure to allergen it develops. Okay, usually on exposure to allergen it develops, and this allergen could be anything. Okay, commonly we say dust allergen. Okay, like this pollen, anything like that, even some animal particles, okay, like from a pet animal, okay, you get that dust or the animal hair and all, that itself can incite an allergy, okay, that can act as an allergen. And what is the allergen cause? The allergen causes something called hypersensitivity. Okay, I'm not going into the detail, but I'm just saying the basic mechanisms. Hypersensitivity. Allergen causes the hypersensitivity in that patient. Hypersensitivity means patient is too much reactive to one particular substance. Normally, every one of us get exposed to that allergen, but we don't always develop asthma, correct? But these patients, due to some genetic problem, they are developing too much of response to that allergen. That is why it's called hyper. Hyper means too much. Too much of response to an allergen. That's why it's called hypersensitivity. And this hypersensitivity manifests as what? Narrowing of the bronchus or bronchoconstriction. Okay, bronchoconstriction. Bronchoconstriction. Can you see that? That is what it's called bronchoconstriction. Are you able to understand this? That's what it's called bronchoconstriction. Okay. And can you understand? Just a minute. Just give me a minute. Just a minute. Sorry. Sorry for the interruption. Okay. Sorry for that. Okay. So it is something which is going to cause narrowing of the bronchus. So that is why. Can you understand two things? What is the type of disease is asthma? It is an obstructive lung disease because it is narrowing of the bronchus. So it's called obstructive lung disease. Number two, what is the clinical feature you are going to get? The clinical feature you are going to get is wheezing, of course. You are going to get is wheezing because when the air passes through the narrow airway, you get wheezing. Are you able to understand this? Okay, that is a characteristic feature. Now, another feature that you may get in case of asthma is that the patient will present with coughing also. Patient will present with coughing. Now tell me, what type of cough is this? Okay, they can have recurrent cough, of course, they can have recurrent cough, fine. But what type of cough? It is not going to be a cough with the sputum, okay? Do you think this is going to cause a lot of mucus production? No, it is simply non-mucus associated cough, or what we also call as a dry cough. Dry cough, another name for this is non-productive cough. This is very important because in COPD also, that is chronic bronchitis also, I told you, cough will be present. But what type of cough is there in chronic bronchitis? It's a wet cough. It's a wet cough. Do you see that? Here I discussed about chronic bronchitis. There I had mentioned recurrent cough, but see here, it was a wet cough because it is characterized by a lot of mucus production. Whereas in asthma, you don't have a lot of mucus or it is a dry cough. That is what you need to remember. Okay. So this is something which you should remember. One more thing. When I discussed about COPD, there also I told you it was a obstructive lung disease only. But was it a reversible condition or an irreversible condition? I told you in the beginning itself that COPD is an irreversible condition, whereas asthma is something which is reversible. That means you think like this: you have a patient who is presenting with wheezing and coughing, and if it is continuing to have wheeze and cough throughout, then you call it irreversible condition. It may be chronic bronchitis. But in a patient with asthma, after some time, the wheeze will get settled and the cough will get settled. That is why it is called reversible. So these are the three main features which I want you to make a note of. Three things are there. One is narrowing of the bronchus, manifesting as wheeze. Second thing, it should be a recurrent condition, correct? Not that a patient is presenting with wheeze first time itself, you will call it as asthma. No, impossible. Okay, you should have multiple episodes to be called it as wheezing. Any idea how many episodes? It should be more than or equal to 3 episodes of wheezing. More than or equal to 3 episodes of wheezing. Clinically, then only you will call it as asthma. And third thing is that it should be reversible. How do you define this reversibility? I'm putting a star because this is supposed to be the hallmark feature of asthma. Anything which is not reversible is not called as asthma, as simple as it is. Okay. So how do you say it is reversible? It can be reversible either spontaneously, that means we settle spontaneously without doing anything, or after giving a bronchodilator. What is the typical bronchodilator we give? Think like this: salbutamol. Or after giving a salbutamol, it is settling. Then we can call it as reversible conditions. Reversible either spontaneously or after giving a salbutamol nebulization, something like that. Then you call it as a reversible condition. This is something based on the clinical criteria. This is how we say clinical. Wheeze is settling on its own or after salbutamol. We can also define this based on the lab parameter. Any idea what is the lab parameter we use? The lab parameter is FEV1. Okay, it is FEV1. We were discussing some time back what will happen to the FEV1 in case of obstructive lung disease. I told you FEV1 will be decreased. In asthma also, during wheezing, FEV1 will be decreased. Now, how do you say it is reversible? Very simple. We document FEV1 at the time of wheezing. It will be low. Definitely it will be low only. And what you will do, you will give salbutamol to the patient. And again, you will check for the FEV1. What do you think will happen? Very simple. Asthma is a reversible condition. So the FEV1, which was initially decreased, now becomes increased. That means the value will keep increasing. How much increase we will call it as response? It should be more than or equal to 12%. It increases by more than or equal to 12% after giving salbutamol nebulization. Then we say that it's a reversible condition and it is suggestive of asthma. Are you able to understand this, doctors? Okay, are you able to understand this? It's very simple only. How do we define asthma? It's a very simple and a very straightforward condition. Only thing, it should not be only one episode, it should be multiple episodes. Number two, it should be a reversible condition. Then only you will call it as asthma. Clear? Okay. So that's about the definition part of asthma. Second thing is about types of asthma. There are two types as I have written. One is called extrinsic asthma, another one is called intrinsic asthma. First of all, I will write extrinsic asthma is the common type. Extrinsic is the common type. Okay. So what is this extrinsic? Extrinsic is something like the source, or it is something like outside. Extrinsic means outside. This is what is a typical type of asthma, also called as an allergic type of asthma, wherein the patient gets exposed to an allergen from outside. It may be a dust, it may be a pollen, or it may be something like a pet animal, something like that. From outside, the patient is getting exposed and developing wheezing. That is called as extrinsic asthma. And this is a typical type of asthma where the onset begins in the childhood itself. It's a childhood onset. Please remember this. It is childhood onset. That's what you need to remember. It is of childhood onset. And usually these children, they have a positive family history, like father or mother having a history of asthma, typically associated with the positive family history. And this is a condition, I told you, it is allergic. So whenever it is allergic, it is mediated by which immunoglobulin? This I think most of you should be able to tell. This which type of immunoglobulin mediates allergic manifestation? Yes, it is immunoglobulin E, number one. Number two, what is the main cell in the WBC which is involved in causing allergic manifestation? It is eosinophil. So what will happen to the eosinophil count? It will increase. What will happen to the IgE levels? That also will be increased. So this is typically characterized by increased levels of IgE as well as increased levels of eosinophils. Increased levels of eosinophils. So please don't forget this. This is important. This is very characteristic also. In fact, not only for asthma, most of the allergic diseases we say IgE level is increased as well as eosinophil levels also increased. This is the common directive asthma wherein exposure to an outside substance will cause problems. Then what is the next one? Intrinsic. Intrinsic means it is opposite. What is that? It is non-allergic. There is no outside exposure. Just like that, the patient develops repeated episodes of wheezing. This is something which is of adult onset. Usually of adult onset. And next thing is that here also there may be some triggers. But the trigger is not like an allergic substance. The trigger is something like a respiratory infection, something like that. Trigger is something like an infection. Or it is something like cold air, something like that, which is triggering the episodes of asthma. You call it as non-allergic asthma. Means it is not an allergen, it is triggering the episode. It is some non-allergic substances like a disinfection or cold like that is exposed. And the point to be noted is that here we may not always get this increased eosinophils and all. No, because it's a non-allergic type. But this type of asthma is a very dangerous type. It's a severe variety. That is the point to be noted. This type of asthma will not usually respond to the usual medication. We may have to use high dose of medication or different type of medicines to control this asthma. Fortunately, non-allergic types or intrinsic types are rare. It is the allergic types which are common. That's what you need to remember about. Okay, fine. Now, one of the intrinsic type of asthma which I want you to remember is something which is associated with this triad called as a Samter's triad. Can any of you attempt the Samter's triad? Which condition you get Samter's triad? Anybody? Okay. Which condition you get Samter's triad? Any comments about this, doctors? Samter's triad. Okay, so this is a condition which is again an intrinsic asthma only. But here, what triggers the episode? It is something like a drug. That is the clue actually. Something like a drug which triggers the episodes of asthma. Which drug? Yes, it is aspirin. Very correct. It's a aspirin-induced asthma. It is the aspirin-induced asthma. Okay, aspirin-induced asthma, or it is also called as aspirin-sensitive asthma. Aspirin-sensitive asthma. Okay, right? And this is a condition which is of adult onset, meaning what? It's usually a intrinsic type of asthma. That's what. And the main problem maker here is the aspirin. Main problem maker is the aspirin. Any comments, anybody? Okay, first of all, I'll tell you the triad, and then I will tell you about how this is causing all the problems. This is a triad. So you think like this. This is a triad of manifestation. One, of course, is the asthma. Second, of course, is the aspirin exposure. It's already there, aspirin exposure. Third is something which you should remember as in addition to asthma, what are the other manifestation? It could be nasal polyp and sinusitis. Nasal polyps and sinusitis. So something like 3 features only. Okay, right? Third feature is something which is extra in the part of triad, which you should remember. So asthma, aspirin exposure, nasal polyps and sinusitis. Okay, fine. So let us just clarify only one part. How is aspirin implicated in causing episodes of asthma or bronchoconstriction? Right? That's what you need to remember. Now, if you can remember this pathway, this is what is the pathway for production of 2 things. What are the 2 things? From phospholipid arachidonic acid, you get prostaglandins and leukotrienes. And the pathway is named after the enzymes which are involved. What is that? For prostaglandin production, it's called COX or cyclooxygenase pathway. For leukotriene production, it's called LOX or lipoxygenase pathway. The way to remember is L for L. Leukotriene, lipoxygenase pathway. Prostaglandin is cyclooxygenase pathway. Okay. Now, whenever you give aspirin to a patient, okay, whenever you give aspirin to a patient, the point to be noted about this aspirin is that it causes inhibition of this particular enzyme. Which enzyme does it inhibit? COX or LOX? Just give me a moment, doctor. Just a moment, doctor. Please, just a moment. You can comment your answer. Yes. What does it inhibit? COX or LOX? What does it inhibit? Yes, it is going to inhibit the cyclooxygenase pathway. It is going to cause inhibition of cyclooxygenase. So when COX is getting inhibited, what will not be produced? Prostaglandin will not be produced. Are you able to follow? Very simple. When prostaglandin is not produced, what will the arachidonic acid be diverted to? Arachidonic acid will be diverted to LOX pathway, and what will be produced? Leukotrienes will be produced. The levels of leukotrienes will be increased. That is what I'm trying to say. The levels of leukotrienes are supposed to be increased. Okay, just a minute. There's a small discussion. Just a minute. Okay, so you can just tell me, like, what will happen? The levels of leukotrienes will increase. Okay, this will result in increased levels of leukotrienes. So aspirin will result in increased levels of leukotrienes. Okay, I'm writing like that, leukotrienes. And this is where the problem is going to start. Why? Leukotrienes will cause what problem? They will cause bronchoconstriction. Leukotrienes will cause bronchoconstriction. And this is what is going to result in wheezing episode. I hope you're able to follow this. Okay, that is how aspirin is involved in the causation of asthma. But this is not something like everybody is going to develop. Only few set of patients will develop. And if a patient develops wheezing episode on exposure to asthma, we will call it as aspirin sensitive asthma. So obviously, what should be the management? These patients should avoid taking aspirin altogether. That is the point. Is that clear? Okay, they should avoid taking aspirin altogether. Are you able to follow this, right? So this is very, very simple only, where wheezing is triggered by increased levels of leukotrienes. That's all. Is that clear, doctors? Fine. Okay, fine. So now, this is what you should know about asthma as a basic introduction. Now, what most of your questions are going to be asked upon, your questions are, how do you manage a case of asthma? And management is always based on severity. Okay, see, nowadays so many modifications have come in the management of asthma. Okay, but the principles of asthma treatment, if you can remember, that is more than enough for your exams. Okay, only 2 type of questions I have seen regarding management of asthma at your exam level. One, they ask you about routine management. That is what I'm going to discuss next. Second is something called acute exacerbation, where patient present with sudden worsening. Something like I told you, for COPD also, there is something called acute exacerbation of COPD. Something like that, there is acute exacerbation of asthma also. How we are going to manage? These are the 2 type of questions which are usually asked for your exam. First, we will say the routine management. For example, you have diagnosed a patient with asthma how we are going to manage that particular patient. That is a routine management of asthma. As I have written already, it is all based on the severity of symptoms in this particular patient. Okay. How do we divide that? We divide it into two grades. Can you see that? Intermittent grade and one more is called as a persistent grade. Very simple only. It is not very difficult and all. What do we say is, what do we ask is, we ask the patient, how many times you are having the symptoms in a week? Like that we ask them, how many times you are having wheezing episodes or breathing difficulty in a week? If it is less than 2 per week, if it is less than 2 per week, you call it as intermittent asthma. Okay. If it is less than 2 per week, it's called intermittent asthma. If it is more than 2 per week, you will call it as persistent asthma. So, what is it? 2 defining? 2 is by the number of episodes. That's all. 1 or 2 episodes per week, it's called intermittent asthma. More than 2 episodes per week, it's called persistent asthma. Are you able to follow this? Okay. Right. So now, persistent asthma, you can see again is divided into mild, moderate, and severe. But first, I would want you to know basic difference between managing an intermittent asthma and a persistent asthma. What is that? Intermittent means the number of the number of episodes are very, very less. Correct? The number of episodes are very less. So, do you want to treat this patient daily, or whenever the symptoms occur, you can treat it? Very simple. Whenever the symptoms occur, you can treat this patient for intermittent cases. I hope you're able to follow this. Intermittent cases, as and when symptoms occur, you treat it. That's all. This type of treatment is what we call reliever treatment. Reliever means as and when required, you give the treatment. That is called as reliever treatment. That's all. Then, persistent means what? More number of episodes every week. So this patient will require treatment, but you should give him daily treatment. Are you able to follow this? You have to give him daily treatment. And daily treatment you give is what we call it as controller treatment. Okay, so just remember like this: relievers are something which are required whenever required. Okay, or are given whenever it is required. So I'm going to write like this: relievers are given as and when required. As and when required. Are you able to follow this? This is what we call relievers. Okay, controllers means you give it on a daily basis. You give it on a daily basis. This is the first thing you have to remember. Okay, relievers, as and when required, you give. That's all. Controllers, you give it on a daily basis. Where will you give controllers? Okay, you will give controllers only for persistent cases, whereas intermittent cases, only relievers are required. That's all. Okay, so I'm going to write like this: relievers are required for persistent cases. You will give them. You will give for intermittent cases. There is no need for controllers. That is the point I want you to remember. Okay, right? Whereas persistent cases, you have to give relievers on a daily basis. And persistent cases also can have exacerbation, right? They can have suddenly wheezing also. For them also, you need to give relievers as and when it is required. So very simple. Intermittent cases, you only give relievers. Persistent cases, you give both relievers and controllers. Controllers, if given, should be given daily. Okay, so now, what are the medications you can give for relievers and for controllers? Okay, for relievers, any medications you can think about? For relievers, any medication? Any idea? The type of medication for relievers, if it is a child, please remember this: in children, the type of reliever that is required is a salbutamol. That is the point. It is a salbutamol. Okay, it is salbutamol. And for a adult, there has been a change in the treatment regime. Any idea what we are using in adults? In adult, we are using combination of ICS plus formoterol. ICS plus formoterol. See, ICS means what? Inhaled corticosteroids. ICS means inhaled corticosteroids. You can write it below. ICS means inhaled corticosteroids. Okay, I hope all of you know what is formoterol. What is formoterol? Formoterol is a long-acting beta agonist. That is what is recommended. So please remember, for reliever, for a child, it is salbutamol, but for an adult, it's a combination of inhaled steroid plus formoterol, which is required. That is what you should remember. What about controller medication? Controller medication means you give it daily. I told you. What is the daily thing which is given? Yes, it is again inhaled corticosteroid. Daily you give inhaled corticosteroid. That is what you need to remember. Okay, I hope you're able to follow this. So again, quickly revise. For an intermittent case, only relievers are required. For a persistent case, both relievers and controllers are required. Okay, reliever is either salbutamol for a child or combination of ICS formoterol for an adult, whereas controller is only inhaled corticosteroid. That's what you need to know about. Okay, next what we need to remember is, can all steroids be given by the inhaled route? Is it possible, first of all? Can we give all the steroids by inhaled route? It is simply not possible because not all steroid will have a mechanism of action like that. So what do? We select few steroids which can be given by the inhalation route, inhaled steroid, ICS. The best example of inhaled corticosteroid is budesonide. Please remember this. The best example is budesonide. That is the number one and the best example for inhaled corticosteroid. Number one is budesonide. Number two, beclomethasone. 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 Number three, cyclisonide. Cyclisonide. And fluticasone. These are the typical examples of inhaled corticosteroid which we are using in India. But just as a common thing which I want you to remember, the commonest steroid which we are using in India is budesonide. That is the commonest steroid which we are using in India. Okay, right? Budesonide comes under the trade name like Budecort and all. That's a common steroid which we are using in India. Okay, just keep in mind that's enough. Okay, right? So yes, I have told you the outline of management. Okay, right? Now, just one more thing I wanted to clarify in the previous pages. How do we differentiate whether it is mild, moderate, persistent? Because we have three varieties there under the persistent itself, right? Mild, moderate, and severe. How do we define it? Very simple. What is the meaning of persistent? Persistent means episodes which are more than 2 per week. That is called as persistent, right? More than 2 per week. Right. Now, if it is not daily, suppose the patient says, I have 3 episodes per week, 4 episodes per week, something like that, but it is not daily, then it is called mild case. Moderate means the patient is having daily episodes, means daily he is having, like 7 out of 7 days he is having symptoms, then it is called moderate persistent. What is severe? Severe is also daily, but as the name itself suggests, the patient will have continuous symptoms. That is the point. The patient will have continuous symptoms. Day and night he will have symptoms. Okay, continuously he will have symptoms. That is called daily symptoms. He will have continuous symptoms. Okay, fine. He will have continuous symptoms. And the symptoms are so continuous that he will not be able to do any normal activity also. He will be telling you, every time I'm having some breathing difficulty, I am not able to do my normal activities. Okay, he will say like that. That is what is called severe. Severe means there is limitation of physical activities also. There is limitation of physical activities. I will follow this. There is a severe limitation of physical activities. Okay, right. That is what is called severe. Okay, so please remember, mild persistent means not daily symptoms. Moderate and severe persistent mean daily symptoms. But in severe persistent, in addition to daily symptoms, the patient will have continuous limitation of physical activities also. Is that clear to us? Fine. Okay. So that's about classification of this particular conditions into intermittent and persistent. You can get questions like that, and you have to answer them accordingly. Okay, right. Now, what has come up in the recent thing is you also have to follow something called stepwise management. Okay, there's something called as stepwise management of asthma. Okay, so what they are saying is not every patient will fit into one of these patterns. So what you do is that you gradually go from one step to another step if the patient is not responding. So this stepwise management is something like what? You start with the step one only, you start with the first step only. And if the patient doesn't seem to have control of symptoms, you go to step 2, step 3, step 4 like that. This is what we call stepwise management of asthma, mainly applicable for adults. Okay, so we will start what is the stepwise management for adults. In adults, what they are saying is suppose you have just diagnosed a patient with asthma. The step 1 would be, see, at the time of diagnosis, you think the patient is having only mild rhinitis, something like that. What you will do, you will give him inhaled corticosteroid plus formoterol combination as and when required. Okay, as and when required. As and when required, you give him inhaled steroid plus formoterol combination. That's what you need to remember. Inhaled steroid plus formoterol combination. This will be the step 1, right? You just tell him whenever you have symptoms, you just take this. Now, suppose the patient comes back to you after a few weeks or few months saying that, no, doctor, this is not enough. I am actually taking this ICS formoterol daily, meaning the symptoms are getting more severe. Are you able to follow? Then what you should do? You should move on to the step 2. What is the step 2? Here, the patient is requiring daily ICS formoterol, means daily relievers is requiring, means he's going to the persistent variety. What you will do for this patient, you will say, you can start taking daily inhaled corticosteroid, daily ICS. Okay, daily ICS you can take, but this time you will use a low dose of inhaled corticosteroid. That is what it is. Daily ICS, but you have to take it in a low dose. That is what. Because anyway, patient is requiring daily steroid, so you will give that as a thing. It's like daily steroid. You give it as a low dose. That's what you need to remember. Then Suppose even with this also, the patient is not getting control, then the next step for the step 3 will be you change to daily steroids only, but you will increase the dose. Daily ICS, but this time it will be medium dose. It would be medium dose. It would be medium dose. Are you able to follow this? Medium means something like increasing the dose. You don't need to know the exact dosages. Nobody is going to ask you that for the exam. But just remember, when the patient is not getting control, you can add, you can increase the dose of daily steroids. That is what you need to remember. Now, along with this, what we are saying is you can also add this long-acting beta-2 agonist. What is that? Formoterol. Daily you can give long-acting beta-2 agonist daily. Long-acting beta-2 agonist daily you can give it. This is what is for step 3. Are you able to follow this? Long-acting beta agonist daily you give. That is formoterol you give. Now, even to this also, the patient is not responding. You have increased the dose of steroid. Along with that, you are giving daily formoterol also. Still, the patient is not responding. Then you go to the step 4. What is that step 4? Step 4 would be again daily ICS, but you will use it in high doses. But you will use it in high dose. Daily ICS in high doses. Are you able to follow? Daily ICS in high dose. Are you able to understand this? Okay. Now, even after this also, the patient is not responding. Then it is going to be very difficult. Step 5. Okay, step 5. What you can use is you can add oral steroid also. You can use a short course of oral steroid. Okay, short course of oral steroid. Okay, you can add short course of oral steroids also. Like for example, 1 day, 2 day, every week you can additionally give oral steroid also. The reason is very simple. Oral steroids have a better effect, but only thing why we are not using oral steroid beginning itself, because you all know that if you use oral steroid for a long period of time, that itself will have its own set of side effects, right? It can even lead on to development of Cushing syndrome also. So that is why we are not using oral steroid to begin with. We are using only inhaled steroid, because inhaled steroid will have effect only in the respiratory tract. That is why we are using that. But if the patient is not responding even to high doses of inhaled steroid, we have no other option other than to add oral steroids. But please remember, it should be only short courses. You should try using the oral steroid. Don't use it for a long period of time. You will end up in a patient having Cushing syndrome also. That is why. Okay, you try to manage with whatever is possible. That's what. And even after this also, the patient is not responding, then you will call it as a refractory asthma. You will call it as a refractory asthma, or something which is very difficult to control type of asthma. And in refractory asthma, you have to use something called as monoclonal antibodies. And if you hear about the monoclonal antibody, it is anti-IgE type of antibody. IgE type of monoclonal antibody. Okay, IgE type of monoclonal antibody. And if you know its name, what's the name of this? It is called, yes, a very famous name which you should not forget, called omalizumab. Omalizumab. Okay, omalizumab. It's an important question. Omalizumab. Okay, right? So just make a note of this. This is important. Okay, this omalizumab. I hope you're able to follow this, right? Yes, correct. So this is the omalizumab which you should remember. Okay, fine. So these are the important things which you should remember. I don't wanted to complicate this. I just wanted to keep it simple. Okay, see, very easy thing to remember is initially patient will have intermittent variety only. So for intermittent variety, you start with inhaled steroid formoterol combination. That's all. Then you keep assessing the patient. Some patient will respond to that only. Your job is done. It's over. But some patients will have worsening of asthma, where they may have to use this relievers daily. So for them, what you will do, you will change over to controllers also. Controllers means you give daily treatment, but starting with daily inhaled steroid. That's all. At some point of time, if the patient is not responding only to daily steroids, you will add long-acting beta-2 agonist also in the form of formoterol. And once you have used the highest dose of inhaled steroid and formoterol also, and if the patient is not responding, then you go to the adding oral steroid. And if that also the patient is not responding, then you go to monoclonal antibody or omalizumab. This is what we call it as a stepwise management of asthma. Okay, one after another, you need to give this type of treatment. So I hope you're able to follow this. So two type of questions can be asked. One is the stepwise management of asthma. Second thing they can ask is about based on severity, how you can manage these asthma. So these are two type of questions which I think are possible for your exams, and you should be knowing about this. Okay, fine. Now, how do we deliver this inhalation medication? That is what is the next question. Okay. Now you can see some pictures I have put up. These are the devices with which we can give the medicine to the patient. Of course, it should be inhalation only because it should go into the respiratory tract. So we can use inhalation medications. So can anybody comment on this? The first picture, the first one which I have put up here. was the 2020 exam question where they put up this image and they asked you, what is this drug delivery device? Can you see it has got two parts? This is the first part and this is the second part. What you have to do is you have to put a capsule like this. This is the tablet or the capsule like that, where you have to put it inside. So you think like this, these are the two parts. What you have to do after putting the capsule inside, you have to connect these two parts. Okay, you have to connect these two parts. What you have to do is you have to do a twisting movement like this. You have to twist like this. So what you do, you connect these two parts, and then once you have connected, you need to twist like this. Once you twist like this, what is going to happen? That capsule will break, and what you will have inside is something like powder like this. Okay, and that powder the patient has to inhale, and that powder the patient has to inhale. Do you know what is this called? This is what we call DPI. What is this DPI? It's nothing but dry powder, yes, inhaler. What is also called as rotahaler. What is also called as a rotahaler. This was a question which came in the exam, like 3 years back. It came in the exam. What is the name of this? It's called as a rotahaler. Okay, so don't forget this. This is important. Okay, this is something where you ask the patient to inhale the dry powders. So that's what it's called, dry powder inhaler. Any comment about the second one? This image. It is something like that inhaler. I think most of you might have seen that. Some of your relatives or neighbors like that using that particular puff like that. What they do? They just press that puff. The drug comes out and they take it, inhale it inside. What do you call that? It is called MDI. It is called as MDI. What is this MDI? It is metered dose inhaler. Please remember this. It's called MDI. It's called metered dose inhaler. Okay, right? Now this is important for you to know. The name. It has not been asked till now, but very well possible that it can come in your exam. Okay, right? Like an image, they can put it up and they can ask you. Okay, yes, very good. It is for asthma only. It is a metered dose inhaler. Okay, right. So that's what you need to remember. Okay, fine. Now, see, why it is called metered dose? Very simple thing. Whenever you press that puff, only certain amount of drug will come out. Okay, so it's a fixed dose which will come out every time whenever you press the puff. That's why it's called metered dose inhaler. Okay, now what you have to do, you have to keep this puff inside your mouth, in the mouth like this, and then you have to press it like this. And what is the important thing? In a single breath, you have to take every drug inside. You have to inhale every part of the drug inside because we want the drug to go into the respiratory tract, right? For that, you have to take a deep inspiration and everything should go inside. Can you expect this type of single deep inhalation for a child to work also? Do you think for a child, with a single breath, every drug will go inside? It's not possible. So for a child, what do we do is something like a modification. What is that? What is that modification? Very simple. This is a metered dose inhaler, correct? MDA. And we will attach a chamber like this. We will attach a chamber like this called as a spacer. And through that spacer, the drug will go inside. What is the advantage of this? See, the spacer will collect the drug which comes up, right? And every time the child is breathing, small amount of drug will go inside. Rather than that, if you ask the child to take everything inside in a single breath itself, what will happen? Not all the drug will go inside. Are you able to understand? Not every drug will go inside. And what will happen? Most of the drug will go waste. So that is why you are using a spacer. The spacer will collect the drug which comes from the metered dose inhaler. And every time the child is breathing, small amount of drug will go inside. So this is the modification which we have to do for children. So please make a note of this. In children, we don't only use metered dose inhaler. We will use MDA along with the spacer. That is the point I am trying to convey. MDA along with the spacer. Are you able to understand this, doctors? Fine. Okay. So these are the drug delivery devices which I want you to remember. Okay. Then we move on to something else. What is that called? This is called management of acute exacerbations of asthma. Okay. Just like I told you, acute exacerbations for which condition? For COPD, there is also something called acute exacerbation of asthma. It is something like typically the patient will say what? Come to you in the emergency room. Patient will come to you in the emergency room and he'll tell you, I am a known asthmatic patient, but now I am having some very increased breathing difficulty like that. That is what is called acute exacerbation of asthma. Of course, in acute exacerbation of asthma, there are two important issues. There are two important problems which you should manage. One problem, of course, is bronchoconstriction. One problem, of course, is bronchoconstriction. Any other problem, doctors? Any other problem also they can have? They can also have hypoxia. Very important point. They can also have hypoxia. They can also have hypoxia. So whenever you are managing a child with or an adult with asthma also, you should be concerned about this particular problem also. Not only bronchoconstriction, it should be hypoxia also, which should be in your mind. So why I'm saying like this? Because whenever that patient comes to the emergency room, the first thing you will give it oxygen inhalation, correct? You will give O2 inhalation. Don't forget this. You should give oxygen inhalation because these patients usually they have hypoxia. First point to be noted. Second thing, of course, you have to give something to control this bronchoconstriction. What is that something? It is nothing but bronchodilator. So you have to give salbutamol nebulization also. You have to give salbutamol nebulization also. And please make a note of this. This salbutamol nebulization should not be given only one time. It should be given 3 times. Don't forget this. 3 times over 1 hour. This is the protocol. That means what? Every 20 minutes once, you have to give a salbutamol nebulization. So that at the end of 1 hour, you would have given 3 nebulizations. Are you able to understand what I'm saying, right? So this is what is the initial thing which you have to do. Give O2 supplements. Make sure the oxygen level remains normal. Then you also give salbutamol nebulization for 3 times over a period of 1 hour. Suppose even after this also, the patient is showing no response. Imagine, even after this also, there is no response. Then what you have to do? The next thing you have to do is very important. You have to give steroids, but the point is you have to give systemic steroid. Systemic steroid. You have to give. Now patient cannot. Now patient is having a severe condition, right? You have to use systemic steroid. So very important, not inhalation steroid. This is what I am putting a star. Systemic steroid you have to use. Any idea which systemic steroid we can use in that emergency situation? Yes, it is hydrocortisone, which you have to use. Very important. Hydrocortisone. Hydrocortisone should be used. Please remember, this is an emergency situation. Whenever you're using a systemic steroid, you have to use hydrocortisone. And even after, see, usually patient will respond after this. Okay, but very unfortunately, even after this, also the patient is showing no response. Then again, you have to go for nebulization only. But what you will do now, you will not give only salbutamol nebulization. You will give nebulization, but combine the salbutamol with one more also. What is that? See, salbutamol is a bronchodilator, correct? But at which level it acts? It acts at the periphery, something like bronchioles, alveoli, like that. It is going to act. That is fine. But if it is going to be a severe condition, you also need to give a centrally acting anticholinergic also. What is that? Sorry, centrally acting bronchodilator also. What is that? Yes, it is an anticholinergic which you have to add. What is anticholinergic? Centrally acting anticholinergic on the central airway. Ipratropium, very important. So please keep a note of this. This is important. Okay, right? So initially you are giving only salbutamol nebulization. If that is patient not responding to that, next time when you give nebulization, you give salbutamol plus ipratropium. This is what is the outline of management in case of acute exacerbation of asthma. Based on this, in the last 2 or 3 years, at least 2 questions have been asked in the exam. You are evaluating a patient who is a known patient of asthma. He comes to the emergency room with a sudden worsening and you hear wheezing on both the sides. All of the following drugs are useful in the management except like that questions have come. For that only you should know about this. Okay. Is that clear? Everyone able to follow this? Right? Everyone able to follow this? Right? Okay. Yes. So I hope it is clear. Clear everyone? Okay. So that completes our list of discussion for asthma. Okay, right? So first I told you about characteristics of asthma. In that I told you, don't forget 3 important things. What are the 3 important things I told you not to forget? One is that it's a condition characterized by repeated episodes of bronchoconstriction. Very important. Repeated bronchoconstriction. Repeated means how many episodes? At least 3 episodes. Then it should be a reversible condition. I told you, if it is not reversible, it is not asthma. What is the example of irreversible condition? It was COPD only, which we have already completed in the last session. Now it was about asthma, which is a reversible condition. Then I told you, management of asthma is always based on the severity, intermittent or persistent. Intermittent means less than 2 episodes per week. Persistent means more than 2 episodes per week. Intermittent cases only give relievers. I told you that. Whereas for persistent cases, you have to give relievers along with controllers. What is a typical reliever? For a child, it is only salbutamol. That's what I've written, correct? For a child, it is only salbutamol. Whereas for an adult, it is inhaled steroid plus formoterol formulation, and that would be the reliever. And as far as controllers are concerned, controllers are inhaled corticosteroid, but the point to be noted is they should be given daily. Very simple. For a mild case, you start with low dose, then you go to the high dose, then you go to the high dose, medium dose, then you go to the high dose of inhaled steroid. That is what is called stepwise management of asthma. even to the high doses of inhaled steroid also, the patient is not responding, then you are going to give an oral steroid short course, and even to that also, you are going to start with omalizumab. This is what is the stepwise management of asthma. Then I told you, in acute exacerbation, we have to manage with different medication, but don't forget two important problems. In addition to bronchoconstriction, this child is also high risk for developing hypoxia. So don't forget, oxygen should be the first thing which you have to give for a patient who's having acute exacerbations of asthma. Is that clear? So that is all about asthma for your exam, which you should be knowing about. I have seen questions being asked nowadays, especially from this management of acute exacerbation. So I'm putting a star for that because this would be a topic to look for in the upcoming exam also in the section of asthma. Clear? Okay. So that's about asthma I have told you. So with that, I have told you two important examples of this obstructive lung disease. What are the two examples I've told you? One was asthma, another one was COPD. One more obstructive lung disease also, which is called bronchiectasis. It is also called as a bronchiectasis. Okay, right? Now, this is something which you have to remember about. See, bronchiectasis as such is not how to say, it is not a clinical topic actually. You don't have a patient who will just present with bronchiectasis. Now, the point about bronchiectasis is that it is purely a theoretical topic, and bronchiectasis is something like an end problem. Like so many problems can occur before, and everything results in the end as bronchiectasis. So bronchiectasis is not like a primary diagnosis. Bronchiectasis is usually due to some other problem. Just like a complication of some other problem, it occurs over a long period of time. Are you able to understand this? So bronchiectasis as such is not a, I don't think it's a clinical topic as such, because patient will not present to you with a typical diagnosis like that. It would be something like the result of so many other problems patient had suffered in the past, and finally he is presenting with bronchiectasis. This is the point which you should have in your mind. Okay, so let us see what is the meaning of bronchiectasis. Always remember ectasis. What is the meaning of ectasis? Ectasis means dilatation. That's all. So bronchiectasis means dilatation of the bronchus. But the point to be noted is that it is a permanent dilatation. Permanent means again it is also a irreversible condition. It is just like a irreversible dilatation of the bronchus. So why do you think this dilatation occurs? Okay, why do you think this dilatation occurs? Okay, let me try to put it like this. I told you so many problems will cause what to say, bronchiectasis. Okay, that problem would be, that's what I've written. Can you see that what I've written? It is usually due to a previous lung problems. Okay, it is usually due to some lung problem is the patient has suffered in the past, and these previous lung problem usually is in the form of infection. Usually it is in the form of infection, and especially in our country, it is post which infection? Tuberculosis infection, post TB infection. This is the overall most common condition. This is the overall most common cause. So think like this: a patient who had tuberculosis for a long period of time, then goes on to develop bronchiectasis. So this is the overall most common condition in our country. Even worldwide, also they are saying most common condition for bronchiectasis is post tuberculosis. What could be the other lung problem? The patient could have suffered recurrent aspiration of gastric contents. So something like, you think like this: he's a neurologically impaired person. Due to neurological impairment, he had multiple episodes of aspiration of feces or aspiration of stomach contents that could have gone into the respiratory tract and caused the problem. So recurrent aspiration can be one more thing. And third category could be something like genetic defects also that can also predispose to bronchiectasis. And I have written already one genetic defect. Can you see that? What is that? It's a very famous condition which I think many of you should be knowing. What is that? Carter-Genus syndrome. Okay, any of you heard about this Carter-Genus syndrome? Yes, I think most of you might have heard in some form or other. It's a condition which is characterized by a problem of the cilia. We all know that respiratory tract is lined by ciliary epithelium, which helps in actually the motility or transport like that. What happens in Carter-Genus syndrome? The cilia becomes non-functional. So it's called primary ciliary. Any name for this? Dyskinesia. Primary ciliary dyskinesia, where the cilia is not working properly. Are you able to follow this, right? I think in your pathology classes and all, you learn more about this Carter-Genus syndrome. The only question which I wanted to ask you here is, this is a condition which is characterized by a triad. Anybody wants to say the particular triad of Carter-Genus syndrome? Any of you know the triad? Any of you know the triad of Carter-Genus syndrome? Yes, it's very typical. Three important things are there. One is called bronchiectasis. That's what it is the condition we are going to discuss about. Number one, bronchiectasis. Number two, sinusitis. Number three, the organs they become completely different. On different side they will be present. For example, heart is normally on the left side, here it becomes the right side. Liver is normally on the right side, here it becomes the left side. So what do you call that? It's called situs inversus totalis. It's called situs inversus totalis. Okay, situs inversus. Okay, we're able to follow this, right? So bronchiectasis, sinusitis, situs inversus, three typical things which are included in the triad of Artaginous syndrome. I hope you're able to follow this. Clear? Okay, so there is number one genetic defect which can be there. Number two genetic defect, please make a note of this. It's a very famous condition actually in pathology. They're going to teach you in detail. Just now, I will give you a brief introduction. It's called cystic fibrosis. Okay, I think you can write it below also. The other condition, you can write it below. Cystic fibrosis. Cystic fibrosis. Any of you know about this condition? This is also a genetic disorder only. It's a condition characterized by defective chloride ion transport. Okay. Defective chloride ion transport. Something like a channel called as CFTR channel. Okay. See, I'm not going into the details right now. In a pathology classes, this will be a long discussion. At least solid 30-45 minutes are required to discuss about this condition. Right now, I'm just telling you that a basic introduction only. It's a CFTR channel. It's a CFTR channel which is involved with the transport of chloride ions. So think like what is going to happen. The chloride ion will not be transported properly. And because of this, the cystic fibrosis will lead on to some situations. Okay, which problem it can result in? It can lead on to recurrent pneumonia or recurrent lung infection. That recurrent lung infection can predispose to the complication of bronchiectasis. This can predispose to the development of bronchiectasis. Okay, this can lead on to bronchiectasis. Number one problem. Number two, it is not only a condition of the respiratory tract. Multiple other areas also affected, including typical example would be GIT also, where they will have malabsorption as a feature also. I have not told you all the points about cystic fibrosis. Something which is very important for our exam purposes. I am just trying to tell it to you. Okay, right? So just make a note of this. This is something which is important. Okay, right? So many other things are there. Some of you are messaging infertility, all those things. Definitely, so many problems are there in cystic fibrosis. Right now, just with the limited space, I'm just trying to tell you not only lung problem, it can also cause malabsorption also. Okay, so what I'm trying to tell you till this point of time is what it is not actually a primary diagnosis. So many other conditions can occur, like repeated infections, repeated aspiration, something like that can occur. And the final thing is that it will be damage to the bronchus, and that too it will be an irreversible damage to the bronchus. So the pathogenesis goes like this. It is usually due to what I told you. It is usually due to some form of other previous lung problem, correct? Some form of other previous lung problems. And all the previous lung problems, what they will do is finally they will cause destruction of the elastic tissue. They will cause destruction of the elastic fibers. Along with that, there will also be fibrosis. There will also be fibrosis of the bronchi. That is what is going to result in bronchiectasis. Okay, so it is basically what happened. It is basically so many lung problems would have occurred in the past, and that would result in development of destruction of elastic fibers as well as development of fibrosis, thereby resulting in irreversible dilatation of the bronchus. Are you able to follow this? Irreversible dilatation of the bronchus. This is what is the condition of bronchiectasis. For your exam, I feel the questions which are commonly asked in exams are genetic defects are something which you have to look for. Number two, overall most common infection following which you have bronchiectasis is post tuberculosis. These are all important questions for your exams, I feel. Okay, that is what you need to remember. Okay, now you can see in the picture, I have put up like this. What is that? Types of bronchiectasis. Can you see? This is normal. The first one is a normal. This is the normal one. And all the other things, all the other three things are abnormal types of bronchi. Can you see that? Cylindrical type is there, depending on how the dilatation looks like. Okay, more like wide and like a cylinder type is for cylindrical type. Then varicose type we have, cystic type also we have. Any idea which is the most common type? The most common type? The most common type is this one. Cylindrical type is the overall most common type. It's a pathology MCQ question. The most common type of bronchiectasis is the cylindrical type. Just make a note of it. One more question also is possible. What is the most common area? What is the most common area which is affected by bronchiectasis? It is the left side lower lobe of the lungs. It is left side lower lobe of the lung. It's the most common area affected by bronchiectasis. Okay, just these are some additional points only which I'm just trying to tell you. Not anything very specifically I've told you. Just facts. Most common is the cylindrical type, and the most common area of the lung affected is the left lower lobe. Okay, so now what do you think would be the clinical features of this particular condition? Any answers? What do you think would be the clinical features of this condition? See, a normal trachea and bronchus would be something like this, right? This is the normal trachea and the bronchus. What would happen in case of bronchiectasis? In case of bronchiectasis, the bronchi will become so hugely dilated like this. This is what is a abnormality. This is what is the bronchiectasis we are talking about. Okay. Any pointers, doctors? Any pointers? Just think about like bronchiectasis only. Just think like bronchiectasis only. That is chronic inflammation going on inside the bronchus. So what will happen? What will happen to the mucus production due to a lot of inflammation going on? The mucus production will increase, correct? The mucus production will increase. So how do you think the patient will present with? The patient will present with repeated episodes of cough. What type of cough? Wet cough or dry cough? Obviously, when mucus is present, it will be a wet cough. So that is what it is. It is excessive sputum production, and that too foul smelling sputum. Foul smelling sputum. Excessive foul smelling sputum along with the cough. That is what you need to remember. This is very, very important wording. Foul smelling sputum. Excessive foul smelling sputum with cough production. This is a classical feature of bronchiectasis, which you should remember, number one. Number two, what happens is that whenever the bronchus is becoming so hugely dilated, there would be erosion of a blood vessel. Think like this: in the bronchi, there are blood vessels, right? There would be erosion of the blood vessel in the wall of the bronchus. Erosion of the blood vessel. I will write like this, the full wordings. Erosion of the blood vessel in the wall of the bronchus. Okay, erosion of blood vessel in the wall of the bronchus will be there. And because of this erosion, what can happen? The blood vessel will start bleeding and the blood will come out. When does it come out? When the patient is going to cough out, at the time, the blood can also be coming out. So what do you call this? Coughing of blood due to leakage from a blood vessel. This is called hemoptysis. The number two feature is hemoptysis. Okay, hemo means blood. I think all of you should be knowing this. Tysis refers to the sputum which is coming out. So blood in the sputum which is coming out. So this is hemoptysis. Okay, so two important things: foul smelling sputum with a cough. Second is hemoptysis. These are very important things. Third thing is that if you start auscultating the patient, you will get coarse crackles. This is important. Coarse crackles. I think all of you know crackles refers to the crepitations or the bubbling sounds like that. You can get coarse crepitations in this particular condition. But the point is that it is varying with position. It will vary with the position. That is the point to be noted. Vary with the position. That's what you need to remember. Okay, see, basically because this is something related to the bronchus, correct? Something related to the bronchus area. So when you vary the position of the patient, what will happen? The mucus will go to different parts of the lungs. That is why different types of, that is why different areas you can get crackles or crepitation. So the key point is that coarse crackles will vary with the position. That is a key word here. Why this is important? Little later also, I will tell you some other condition called coarse crackles that won't vary with the that won't vary with the position. Okay, I will compare at that time. This is something which will vary with the position. Please don't forget this. This is important. Okay, so three things which I want you to remember: one is the foul smelling sputum, second is hemoptysis, and third is the crepitations of the crackles, which will vary with the position. That is the point to be noted. Now, what is the problem here? The problem is that these patients, are prone for repeated infection. They are prone for recurrent infections. Okay, please make a note of this, especially what type of infection. This can be a potential question for you. What type of infection these patients can develop? One is the Staph aureus infection, and number two is the Pseudomonas infection. Please make a note of this. Pseudomonas infection. So this is something which is very dangerous. Why? Because repeated infection can lead to bronchiectasis, and bronchiectasis can also lead to repeated infection. So this will go on like a cycle: infection, repeated infection, bronchiectasis, repeated infection, then again bronchiectasis. So it will go on like a cycle. So that's what I was trying to tell you. This is a irreversible condition. So can you correlate? This is a irreversible condition. So once this starts, there is no endpoint for this. Ultimately, the patient will succumb to the disease only. That is what you need to remember. Okay. So I feel for your exams, it is more like a theoretical question only. Not much of case scenario questions are expected, but they can give it very well like this. You have a patient who had a long-standing history of tuberculosis. Many years later, he presented with the complaints of foul-smelling sputum with a chronic cough, along with hemoptysis. Which condition can be suspected? You can answer as bronchiectasis. Are you able to understand this? All the other type of questions in bronchiectasis are all one-liner question, including this question. What is that? What is the investigation of choice for this particular condition? I think at least 3 times this question has been asked. Okay, in the past few 5 years like that, this question has been asked at least 3 times. What is the investigation of choice for bronchiectasis? This is more like a radiology question. Any comments on this? What is the picture depicting? That picture is depicting the X-ray or the CT. Very simple. That X-ray, yes, it is something like the CT only. It is something like the CT. But a foul smelling sputum is because very, very simple. This mucus is something which is there in the respiratory tract without being expelled out, correct? And when it is staying in the respiratory tract itself for a long period of time, it will become foul smelling. Not only that, I told you this condition can predispose to infection. That infection also will make the sputum to be like a foul smelling sputum. Okay, so foul smelling tells you that the mucus is there for a long period of time inside the respiratory tract, which makes the smell like a foul smell. That's all. Okay, fine. So now coming to the investigation of choice. What is the investigation of choice? This is the CT. It is not the conventional CT. It is actually called HRCT. I hope all of you know what does HRCT stand for. It is high resolution CT. High resolution CT, which is the usual exam question which comes in the exam. Now, even better option would be helical CT. Helical CT also. That is even more precise CT also. Okay, right. So whatever is there in your paper, you can mark it. Usually, I think HRCT is given in your paper, so you can mark that. But if helical CT is given, please choose that as a better answer because that is supposed to be the best investigation overall. If not given, you can choose HRCT. So what can you see in that particular HRCT? Any comments about this? Any comments about this picture? Any comments about this picture? First thing you can see is that the dilated bronchi. Can you see that? These are the dilated bronchi which I'm tracing out. How are they looking? They're looking like train tracks. Can you see that? They're looking like the train tracks. So what do you call this appearance? It's called tram track appearance. It is called as a tram track appearance. Can you see that? This is a typical tram track appearance which I have put up in this particular city. Second thing, sometimes the bronchus are not seen like a tube like this. They are seen in a cross-sectional view. They are seen in like a cross-sectional view. Whenever you see in a cross-sectional view, they will appear like all these round areas. Can you see that? All these round areas. Any idea what is this called? All these round areas. What do you call them? There are two names for this. One, it is called as honeycomb appearance. Can you see that? It's something like a honeycomb appearance. Honeycomb appearance. And if you see one round area, it is something like a small ring like this. Okay, small ring like this. So people called it as a signet ring appearance also. It's called as a signet ring appearance also. So three important names I want you to remember regarding the HRCT findings in case of bronchiectasis. One is the tram track appearance. Second one is the honeycomb appearance. And third is the signet ring appearance. I hope you're able to follow this. Is it clear? I'm able to follow this. Okay, right? So very characteristic. So three important appearances: tram track, honeycomb, and the signet ring appearances. Okay. The usual question for you is they may not ask you the appearances, but they can ask you what is the investigation of choice. For that, answer is going to be HRCT. Without any doubt, it is HRCT. Okay, right. Now I told you this is an irreversible condition. You will not be able to treat this particular condition. Maximum what can be done is only supportive treatment. That supportive treatment will be mucolytics. You can give some drugs like this ambroxol and all, which can help in lysis of the mucus because in this condition you get lots and lot of mucus production, right? So mucolytics can be given. And of course, whenever the patient bringing out lot of sputum, lot of mucus outside, he will also be dehydrated. So definitely hydration is also an essential part of the management. Third thing is physiotherapy. Now, why physiotherapy? Because I told you these patients have a lot of sputum or mucus which is inside the respiratory tract itself. So when you give physiotherapy, it will help to drain out the mucus, So when you go to the wards and all, you will see that these patients, almost every day, a physiotherapist will come and try to put the patient in different position so that all the mucus from inside the respiratory tract comes to outside. So it is basically to drain out the mucus from the bronchus. And third, of course, I told you, this condition itself can predispose to repeated infection. So definitely you have to give antibiotics for infections like that. The common antibiotics which are recommended is based on the organisms only. I told you like staphylococcus and all can cause. So the initial respiratory antibiotic which we prefer is ciprofloxacin in these patients. And sometimes if the patient is having pseudomonas, see I told you the second type of infection can be pseudomonas. For pseudomonas, you may have to use a better drug also. Any idea which drug can be used for pseudomonas infection? Pseudomonas infections, any idea? Pseudomonas? Yes, for pseudomonas, you have to use which one? Something like a higher antibiotic. Piptaz. What is this piptaz? Yes, piperazine, tazobactam, or you can use something like a higher group of cephalosporin, which is ceftazidime, can be used. Okay, ceftazidime can be used. Okay. Okay, so these are the things. Basically, what I'm trying to tell is we cannot cure this condition. All these comes under the supportive category. That's all. All these come under the supportive category. Don't forget this. Okay, fine. So these are the essential aspects in the management of this particular bronchiectasis, which I want you to remember. So mostly it is all about one-liner questions only, I feel, for your exams. But clinical scenario can also be there. In that, typically the question will be starting like patient who had repeated infections or something like tuberculosis, and after that presenting with foul-smelling sputum and hemoptysis. That is how the question will be there. The one-liner question usually are, which is the overall most common cause of this? The overall most common cause is post-tuberculosis. That is number one-liner question. Number two one-liner question, what are the genetic conditions which can predispose to bronchiectasis? Two things at a level you have to remember. One is Cartagena syndrome, and second is cystic fibrosis. Third important one-liner question, the investigation of choice, it is HRCT, and the typical appearances I've already given in that particular image: tram track appearance, honeycomb appearance, and signet appearance. Okay, is that clear? So that's about bronchiectasis, which I want you to remember. So with that, I have tried to tell you some of the important examples of obstructive lung diseases. Okay, can you see that in that initial thing? Just you don't need to take it. I'm just taking up that particular area where I told you obstructive lung disease. Can you see? We have covered about asthma, we have covered about COPD, and we have also covered about bronchiectasis. Next, I am moving on to the restricted lung disease category. In the restricted lung disease category, I told you the most important category is the parenchymal lung diseases. This is a parenchymal lung disease called as a name interstitial lung disease. That is what we are going to see next. Interstitial lung disease. Okay, please take from your next page and also take it up from the next page. Yes, something called interstitial lung diseases. Okay. Now, this is a topic again which is more of theoretical importance. I would want to put it like this: it is more of theoretical importance because clinically these topics are very, very rare. Okay, clinically these conditions are very rarely encountered. So it is more like a theoretical topic only. We'll just quickly finish that part. Okay, I will also tell you something in between. Immediately can be asked in your exams, especially one area in interstitial lung disease, which I will be discussing in detail. But other than that, most of the things, whatever I have seen for the exams, are all theoretical topics only. They're all mostly theoretical topics, which I want you to know about. Okay. So let us get started. First thing is called interstitial lung disease. Okay, yes, interstitial lung disease. First of all, you should know the meaning of what is interstitial. Any comments? What is interstitial? Interstitial means something like in between. What is that in between area? You think like this. I'm just drawing for the description purpose. Think like this as the alveoli. This as the alveoli area. Alveoli. And you all know that alveoli is the area of where the oxygen enters into the lung. And where does it enter? It will enter into the blood vessel, correct? So think of this as the pulmonary capillary. Think of this as the pulmonary capillary or the blood vessel. Then what is the interstitium? Then what is the interstitium? What is the interstitium? Any comments? Anybody can comment on this? The area in between the alveoli and the blood vessel. This area, right? This area is what we call it as a interstitial area. This is called as an interstitium. And what is the interstitium? This is the area through which oxygen goes inside and carbon dioxide is expelled outside. So can I say like this? This interstitium is the area where actually the gas exchange is going to occur. This is the area of gas exchange. This is the area of gas exchange. I hope you can follow this. This is the area of gas exchange. Okay. Now, interstitial lung diseases are a condition wherein there is a problem in this particular area. The problem is usually like this. Initially, what happens in the interstitium? There will be inflammation in the interstitium, and over a long period of time, it would lead to fibrosis in that area. So the final picture would be something like this. The final picture would be like a lot of fibrosis developing in that particular area. Very simple. There will be a lot of fibrosis in this particular area. There will be a lot of fibrosis in this particular area. This is what is the basic pathology of interstitial lung disease. So the main focus which I want you to remember is the patient will have inflammation of the interstitial area or the area of gas exchange. Followed by that, there will be fibrosis of that area. That's all. That is what is the main pathology of interstitial lung disease. Now we move on to something called the types of interstitial lung diseases, and there are so many types. As you can see, 5 types. We classify them or something based on the etiology only. We are just trying to tell you. Okay. You can also write like this. Instead of types, you can directly write etiology. Okay. That is also a better word to remember. Etiology of interstitial lung disease. Please remember, most common thing is we do not know the etiology. That is why it is called as what? It's called as idiopathic pulmonary fibrosis. Can you see that? We do not know the reason itself. That's why it's called idiopathic pulmonary fibrosis. And in pathology, they use the word which has been asked for your exams also. In pathology, the word for this idiopathic lung or pulmonary fibrosis is that it's called UIP. It's called UIP. What is UIP? It is a usual pathology, right? Most common means what? It is usual. Usual. What is that? Interstitial, because it's a condition involving the interstitium. So usual interstitial pneumonitis. Okay, it is called usual interstitial pneumonitis. That is the word which we use in pathology. The point I wanted to convey is it is the most common type where we do not know what is the reason at all. That's all. Okay, this may be the most common type, but the most important one for your exam, that is why I'm putting a star like this here, is something called as a occupational lung disease, which is going to result in interstitial fibrosis. What is the name of that occupational lung disease? It is called pneumoconiosis. Pneumoconiosis. This is something which I'm going to discuss in detail also. That's something which is very important for the exams also. Pneumoconiosis. Okay, right. We'll be discussing that in detail, doctors, right? Pneumoconiosis is basically due to something like exposure to dust or mineral, something like that in the air, through the air. By inhalation, you get that. And that dust will cause problems inside the lungs. Okay, there are so many types of exposures possible. Like you might have come across some names, even in your PSM classes also, they might have told you like this. What is that? Silica exposure, silicosis, asbestosis, bicyanosis, so many names are there. But the point which I want to tell as an MCQ straight away here itself is that the most common type of pneumoconiosis in India, it is silica exposure or silicosis. It is silicosis. That is the point which I want you to remember. It is called silicosis. The most common type is silicosis. Okay. This is the second common etiology. Third important is drug association. Yet another important topic for your exam. I think even in your pharmacology classes, they might have told you about some drugs which can cause interstitial lung disease or fibrosis. The name of this condition is called non-specific interstitial pneumonitis. That's a pathology related name. Non-specific interstitial pneumonitis. Now, for your exam, what are the drugs which can cause interstitial fibrosis? That's an important MCQ question. Any of you know about some drug names? Any of you know about some drug names which can cause interstitial fibrosis? I think maybe in your pharmacology classes, they would have emphasized this particular point. Yes. I see some of you are typing in your Telegram things and all. I will not be able to see that frequently, but anyway, it's fine. You can just type in there if it is comfortable for you to type in there. It's fine. But I want you to know about some names. Okay, right? Yes, what is that? A, B, M. Okay, this is like a way to remember this. A for, some of you have already mentioned very correctly, A for amiodarone. B for, any idea? See, these are all something like drugs which are used in the cancer treatment actually. And this is something important. Bleomycin. Two names actually. One is bleomycin. One more is busulfan. And N is for the nitrofurantoin. N is for nitrofurantoin. So three things are there. A, B, M. Amiodarone, bleomycin, and nitrofurantoin. Amiodarone, bleomycin, and nitrofurantoin. Okay, fine. Yes. Prednisolone will not cause this actually. Prednisolone is more like used for treatment purposes. Okay, it is another group of medications actually. Other group of drugs for like anti-cancer drugs which are causing this problem. Okay, right. Okay, fine. So ABN is what you should remember. This is again yet another important topic. Amiodarone, bleomycin, busulfan, and nitrofurantoin. Okay. Then the fourth one I have written like this. What is that? Discominative interstitial pneumonitis. Okay, it's called DIP in the short form. The only important MCQ related to this is that this is the only type of interstitial lung disease which has got association with smoking. Okay, so this is a very potential question. Smoking related interstitial smoking. Just a minute. So just a minute. Smoking related lung disease. Okay, smoking related interstitial lung disease is called discominative interstitial pneumonitis. Okay, these are all MCQ questions. Finally, some connective tissue disorders and a disease called sarcoidosis and more like in your pathology, you may discuss about this, something like vasculitis and all can cause interstitial lung diseases. Okay, right? So this is something which is more of theoretical topic. That is what I was telling you from the beginning. It is more of theoretical topic only theoretical in fact. But the points are commonly asked in your exam. The most common category is idiopathic only. Next, pneumoconiosis, something like important for exam, which we're going to discuss in detail next. Third is something which is associated with the drugs called non-specific pneumonitis. And fourth one is discominative, which is smoking associated interstitial lung disease. Just try to know these things. These are purely pathology names only, but important for your exams as one-liners. Okay. Now let us see how a patient with interstitial lung disease is going to present. What is the main area which is affected? It is the interstitium, and I told you clearly, interstitium is the area of gas exchange. So think like this, gas exchange is not happening. So what problem the patient will have? The patient will have what problem? The patient will have exertional dyspnea. The patient will have exertional dyspnea. So typical finding, they have exertional dyspnea. These are the common clinical features. There are so many different features, but common features I'm putting up. They will have exertional dyspnea. Second thing, of course, they can have cough. But what type of cough they will have? Dry cough or wet cough? Obviously, this is not associated with any secretions and all. It is not in the airway. It is in between the airway and the blood vessel. So it is going to be a dry cough or a non-productive cough. That's what you need to remember. It's a non-productive cough. Okay. Now, third is supposed to be the most important thing, and that is what I'm going to put up as a star. What is that? They can also have crackles. They can also have crackles. They can also have crackles. Again, a coarse type of crackles only they can have, but this is something which is different because previously also, do you remember in bronchiectasis also I told you they can have coarse crackle, but here the crackles will not vary with the respiration. Very important point. It will not vary with position. Sorry, it will not vary with the position. If you can remember for bronchiectasis, what did I tell you? Those crackles will vary with the position. This one will not vary with the position. This is important. It will not vary with the position. And second thing, that crackles, if you hear, you will have a quality, something like a scratching sound. So how that scratching sound will be there, you might have seen that in the bags or something like the common items and all, where you have this Velcro, which is used to as a fastener. Have you noticed that Velcro? I think you can understand this. That Velcro fastener is there, no? Like close and open like that. Whenever you open that Velcro fastener, you will hear some scratching type of sound, right? Same type of quality only you will get in this type of particular crepitations or crackles also. It is called as a Velcro crackles. That is important. It is called as Velcro crackles. Okay, please make a note of this. It's called as a Velcro crackles. The point about Velcro crackles is that something like a quality like that of a fastener. Okay, like that. Okay. So exertional dyspnea, cough, and they can also have crackles or crepitations. Clear? Okay. Most important, according to me, in your exam questions and all, will be about the quality of the crackles. That is why I put a star there. Okay. Fine. Now, last thing, what is the imaging modality of choice? This is the imaging modality of choice which I have put up. What is that? Here again, it is HRCT only. Here again, what is the appearance you are noticing? What is the appearance you are noticing? Here also, you're having the typical dilated spaces like this. What is the dilated things? These are the honeycomb appearance, okay? Honeycomb appearance only. Honeycomb appearance, you can use it in so many spaces, so many things, okay? So, but among the investigation, the better one is the HRCT where you have the honeycomb appearance. It's also called as a reticulonodular appearance. It's also called reticulonodular appearance. Reticulonodular appearance. Let's make a note of this. That's all. Okay. Right. Your usual question is not the name of the appearance. Your question is what is the investigation of choice? It is always HRCT, which will be the investigation of choice. Okay. Don't forget this. Okay. HRCT is the investigation of choice. Okay. Now this is imaging modality of choice. Okay. Please watch out for the question. It is imaging modality. Imaging means what? CT, MRI, X-ray, something like that. But there is one more type of question also which can come. What is it? Overall best diagnostic investigation. Like this also the question can come. Overall best diagnostic investigation. Any idea here? Here it is not even imaging. Here it is not CT, MRI, HRCT and all. What is the overall best diagnostic investigation? We have to take the biopsy itself of the lung and see there. See, because this is an area in the interstitium, correct? Best way to assess the interstitium is by looking at the biopsy specimen itself. So what is that? Through the bronchus, you put a bronchoscopy, and through the bronchoscopy, you enter the lung area and take a biopsy. So this type of investigation, please know the name. It's called transbronchial lung biopsy. This is the overall best investigation. This is the overall best investigation. Lung biopsy, transbronchial lung biopsy. You can even remember lung biopsy also, that is fine. But how do we take that lung biopsy? Through the bronchus only you enter and then take out the lung biopsy. So this is called transbronchial lung biopsy. So don't make a mistake here. Simply they ask you among the imaging modalities, what is the investigation of choice? You can answer HRCT. But if they ask you overall overall best investigation for interstitial lung disease, then your answer will change to transbronchial lung biopsy. I hope you're able to follow this. Everyone able to follow this? Okay, right. So that is about the introductory part of the interstitial lung disease, which I want you to remember. Now, only one thing which I'm going to discuss in detail will be about the topic of pneumoconiosis. And as I told you, this is the most famous topic in interstitial lung disease. Almost like every other exam, okay, whether it's a June exam or a December exam, every year, one question is surely coming from the topic of pneumoconiosis. Okay. And as I already told you, this is more like a theoretical topic only because clinically we don't see much cases, but I don't know, for some reason or other, in your national board exams and all, surely one question is being asked about pneumoconiosis. Okay, so let us see that Again, I'm telling you, this will be more like theoretical points only because we don't see that cases clinically, but it has been again and again asked in your exams. So this pneumoconiosis part is what I'm going to discuss next. Okay, what is the simple meaning of pneumoconiosis? See, pneumo means something like air or the lungs. Coniosis refers to the dust exposure. That is the point. Okay, so pneumoconiosis is something which occurs due to dust accumulation in the lung. Dust accumulation in the lung. Okay, dust accumulation in the lung. That is the simple meaning of pneumoconiosis. Please have this in mind. It's a simple meaning of pneumoconiosis. See, it is not like you and I are going to get this pneumoconiosis, right? We are also exposed to the common dust and all, but that is not going to cause pneumoconiosis. So, who are the persons who are going to develop this pneumoconiosis? Those persons who, as a part of occupation, okay, daily getting exposed to that particular type of dust only, they will develop pneumoconiosis. So that is why this pneumoconiosis is also called as a occupational lung disease. Occupational lung disease. Occupational lung disease. But don't forget, it is not like a person who's going to that particular industry like that for 1 year will get the disease. No, it should be a chronic exposure to that particular dust. And a chronic means like how many years? At least more than 10 years. Like 10 years, 20 years, like that. That type of exposure only is going to result in the pneumoconiosis. That is a point which I want you to remember. It is occupation related lung disease, but over a long period of time only it will develop, like more than 10 years typically. Is that clear? Fine. Now, two names I want you to have in your mind. What are the two names? One is silicosis, one more is asbestosis. Okay, see, there are multiple names actually, but two important ones for your exams are silicosis and asbestosis. Which is the overall most common? I've already told you. Which is the overall most common? Overall most common is, of course, it is only silicosis only, which is the overall most common in India, everywhere almost. Okay, it is the silicosis only, and this is due to inhalation of, obviously it is by air, so it is inhalation of silica, crystalline silica. So it is due to inhalation of the crystalline silica dust. Okay, when it enters into the nose and into the respiratory tract, it is going to cause the problem. And typically, this is something which is involving the minus. Okay, like the stone minus, right? So it's called as a minus disease or stone grinders disease. Okay, typically, no, this those who are involved in this stone polishing or cutting of the stones and all, those are the ones who are going to develop this particular silicosis. So that's why it's called minus disease or grinders disease, like that. Typically, those who are working with the stones, they are the ones who are going to develop this particular condition. Okay, right. And one point about silicosis is that it is highly fibrogenic. Okay, means this particular exposure, okay, may occur now. Okay, may occur now, like today. Okay, like for example, I'm getting exposed to that silica, and over 10 years, I'm getting exposed to silica. Okay, think like this. The problem about the silica is that it is highly fibrous. What happens is that even I am retiring from that industry after 10 years. Imagine, I have retired from that particular occupation itself after 10 years. Still, what happens? This particular exposure, which could have occurred in the first 10 years, would result in progressive fibrosis. That is the point. Progressive fibrosis. So even if I come out from that particular area also, because of my previous exposure, I am going to develop progressive fibrosis. So that is why this is one of the most severe types of pneumoconiosis. It is one of the most severe types of pneumoconiosis because it can lead on to progressive fibrosis and ultimately it will result in death of the patient also. That is what you need to remember. So this is something which is very dangerous. Why I'm saying it's very dangerous? Because it is not only the most common type of pneumoconiosis, it is also the most severe type of pneumoconiosis also. Please have this in mind. Okay, right. And talking about the area affected, usually it affects the upper lobes more commonly compared to the lower lobes. This is an important MCQ question. I'm putting like a Q. Usually affects the upper lobe. And the patient will have usually the same set of manifestations only. What is that same set of manifestation? The patient will have breathing difficulty. When you auscultate the patient will have Velcro crackles. Same like whatever I have told you, because this is also coming under which category? Interstitial lung disease only. So the same set of manifestation only. They'll have exertion dyspnea, they'll have cough, they will also have crepitation, Velcro crepitation. Everything is the same. Clinical features will be the same only. Now, what is the next type of question they can ask in the exam? Is very characteristic X-ray finding. Please take the next page. I have put up that characteristic X-ray finding. What can you see in the X-ray finding? See, it is not very clear in this picture, but what they can have is something like small nodules like that in the X-ray. It is not very clear in this X-ray, but I am saying that this is one of the appearances. Something like nodules. Nodules will be present in the X-ray. Number one, nodules can be present on the lung face. Number one. Usually remember which zones will be affected. Upper lobe will be affected. That's why I put it in the top. Okay. Usually the upper zone is affected. Now you can see something like small arrows which are there pointing to some typical appearance. Can you see all these areas? Can you see all these areas? Any comments on all these areas? And can you see that it is very clearly demarcated like this, round, white colored areas? What do you call that area? It is the hilum area. And you all know that in the hilum, there will be something called hilar lymph nodes will be present, correct? Hilar lymph nodes will be present. So this is something like enlarged lymph nodes only. And what is this white color representing? The white color is representing the calcification. Okay, the white color is representing the calcification. And it is something like what? It's something like an eggshell surrounding that round area only you are having the calcification. It's not fully calcified, right? Only in the borders. So something like an egg, something like an eggshell, there is a calcification. This is a very characteristic finding called as the eggshell calcification. Important MCQ question. Important MCQ question called as the eggshell calcification. Don't forget this. Okay, very characteristic finding associated with silicosis. Okay, and what are the complications in this particular patient? The complication is that this condition is a lung problem. It increases the risk of another problem. What is that? It increases the risk of tuberculosis. We all know tuberculosis is a very common infection in our country, and silicosis is something which will increase the risk of tuberculosis. Okay, right? And also, it is associated with increased risk of lung cancer. Also, increased risk of lung cancer. Not only that, it also increases the risk of COPD in the patient. Again, this is a dust exposure, right? So COPD risk is also increased. That's what you need to remember about. So this is something which is very, very dangerous. Not only most common, it's also very dangerous also. That's what I want you to keep in mind. Okay, fine. So those are all the theoretical points related to silicosis which I have told you. Next, we move on to asbestosis. Please start from the previous page. Asbestosis. Okay. Now, asbestosis, any area in which type of industry is it commonly encountered? Asbestosis. Asbestosis, any area in which type of which one do you want me to repeat? Which one should be repeated? Please be a little specific. Which one to be repeated? Okay, see, I was just telling only one thing. What is that? Silicosis is the most common type, but it is also the most dangerous type because silicosis is not only going to be just a dust exposure. It is not only going to be interstitial lung disease. It is going to cause progressive fibrosis, meaning even after I am relieved from that particular industry also, I continue to develop the manifestation. That is number one. Number two, why it is very severe because it's also associated with increased risk of other problems like TB risk is increased, lung cancer risk is increased, even COPD risk is also increased. So that is why I was trying to tell you that. Okay, X-ray, nothing. X-ray is something like what happens is that there will be calcifications of the hilar lymph node. Can you see that white colored areas which I have marked are the hilar lymph node area? In hilar lymph node, what is going to happen is there will be calcification, but all the calcification will be like in the border or periphery only. It is not that full lymph node is calcified. No, only the border of the lymph node is calcified, and that is what we call it as, the eggshell or the border-like calcification. That's all. And the border is round, looking like an eggshell, so that's why it's called eggshell calcification. That's all. Okay, right. Now moving on to the other one. What is the next one? Asbestosis. As some of you were very correctly saying, this is something which is involved in the textile industry. Very good. I think all of you know about there are so many parts in India which are involved in the export of the textiles, especially in my place, and there are so many areas for textile industry. So textile industry is something which is very unique for exposure to asbestos. Number one. Number two is the shipping industry, like the shipyards on the coastal areas, right? Shipping industries. Okay, people working there are also at particular risk of developing this asbestosis. And if I'm not wrong, like 2 years back, there was a question like this: a long-term worker in a textile industry later developed some lung problems like that, and they asked which type of pneumoconiosis develops commonly in that patient. So the clue was textile industry exposure. That was the clue. You can mark it there as a question itself. One of the previously asked exam questions. Okay, right. And asbestosis, actually, it is of two types. Okay, asbestosis actually of two types. Any of you know about this asbestosis two types? One is called as a serpentine type. Which is what is the commonest type. 95% of the patient get exposed to this type of asbestos only, and 5%, okay, 5% they have another type called amphibold type. Basically, it is based on the type of fibers actually. Amphibold type is like a straight fiber. Serpentine type is like a curled fiber like that. Okay. See, there are many other names also like this. Like serpentine type used to be called as white asbestos. Amphibold type is also called brown asbestos. These are multiple names, but that is not our concern. What I want you to remember is commonest type is serpentine type, but the toxic type, fortunately, is the amphibold type, which is only 5% of cases. So that's what I'm trying to tell. The asbestos exposure is relatively common only, but most will be like the non-toxic form of asbestos. Toxic form of asbestos is something which is relatively very, very rare, And that is a good thing also because we don't get many cases like that. Okay, that is what I want you to remember. It is an amphibole type which is toxic. Purely for your MCQ purpose, you can remember. Otherwise, I don't think there are many questions like that. Okay. Now, in comparison to the silicosis, I told you silicosis is something which commonly affects which lobe, upper lobe of the lung, whereas asbestosis is something which affects commonly the lower lobe of the lungs. Okay, please make a note of this. It affects commonly the lower lobe of the lungs. Okay. Now, type of lesions which are caused by asbestosis. You can see these are all just theoretical points only. Most common is the pleural plaques. Okay, most common is the pleural plaques, and the pleural plaques are usually asymptomatic. Please remember, pleural plaques is the most common type of manifestation, and usually it is asymptomatic. Please make a note of this. And pleural plaques can also be associated with calcifications, and this type of calcification is given a very special name. Theoretical only. Unfortunately, I don't have that picture now. Later, I will put it to you. Maybe after the lunch break or when I put that picture, I will put that X-ray picture also. Okay, right. The calcification is typically something like a candle wax which is dropping down. So it's also called as a candle wax calcification. It's also called candle wax calcification. Something like a candle wax which is dripping down like that. So you get calcification. So some randomly you get calcification. That is called candle wax calcification. This is supposed to be the most common manifestation. Usually, patients are asymptomatic if they have this manifestation. That is the point. Okay. Okay. Next thing which they can ask you in your exam is that what is the earliest manifestation? What is the earliest manifestation? Earliest manifestation is something like a short form which you have to remember. Even the same word can be asked in your exam. It is called as BAPE. What does this BAPE stand for? BAPE stands for B for benign. Okay, please keep that in mind. It is benign. Benign asbestos related PE, that is the word, pleural effusion. Benign asbestos related pleural effusion. Just keep a note of this name. We are going to discuss about pleural effusion as a topic in great detail later on. At that time, I will tell you this is one of the earliest manifestations of BAPP. Okay. Now, there are a few points which I want you to remember regarding this asbestos related pleural effusion. It is an exudative type of pleural effusion. It's an exudate type of pleural effusion. Don't worry about exudate, transudate and all right now. We'll be discussing that later. Okay, we'll be discussing that little later. If you don't have spaces here, you can even continue in the next page also because I've given spaces there in the next page also. There you can also write it. Okay, right? So most common is the pleural plaque, but earliest manifestation is always benign pleural effusion, which is an exudative type of pleural effusion. Okay. And with asbestosis also, there is an increased risk of complications. Okay, in the next page, I think you can write it, complications. What are the complications which can occur related to asbestosis? This condition is associated with increased risk of lung cancers. Okay, increased risk of lung cancers. Okay, what is the common term which we use for this? The most common, what is that? It's called bronchogenic carcinoma. The most common type is the bronchogenic carcinoma. I think in your pathology classes, you learn so many names related to bronchogenic carcinoma, right? Adenocarcinoma, squamous cell carcinoma. Every variety can be noted, but it is the most common type of lung cancer which occurs in this patient. Number 2 is the specific type of cancer. This is an important question. I'm putting a lot of Q like that. It's a very important question. Most specific type of lung cancer is something related to the pleural cancer. Pleura is one of the mesotheliums. I think all of you know pleura, pericardium, peritoneum are all like mesothelial things. Okay, mesothelium. Okay, so this type of cancer is what we call mesothelial cancers. It is called as a mesothelial cancers or called mesothelioma. This is an important MCQ question. Most specific type of cancer associated with asbestosis, it is mesothelioma. So much so that whenever you see a patient who is diagnosed to have mesothelioma, the only possibility or the usual possibility is he might have got exposed to asbestos previously. That is what should be remembered. So that is why I'm writing specific type of lung cancer in asbestosis is mesothelioma. Are you able to follow this, right? So these are all almost like purely theoretical points. That is what, okay, in purely theoretical points. Okay, fine. So that is what you need to remember about. So these are important examples of pneumoconiosis. Please make a note of this. I think even in the last exam also, there was a question about, I think, silicosis. Okay, that was a question. Okay, right. Fine. Anyway, so silicosis and asbestosis, the two important ones for the exams are that. Okay, just a quick note about the other things. You can write it. Cold workers pneumoconiosis. Again, it is something like exposure to coal as a part of industry exposure. Coal is something which is black in color, so that is why this type of lung disease is also called black lung disease. It's also called black lung disease due to exposure to a lot of coal. Okay, and it can be of two varieties. One is called simple cold worker pneumoconiosis. Another one is called complicated one. Simple is something where the patient is asymptomatic. asymptomatic. And only thing which develops in the lung is something called as a cold macules. That's all. Cold macules, or sometimes like nodules. That's all. Here, the patient is usually asymptomatic. Don't forget this. Patient is usually asymptomatic. Complicated means a condition which is very rare only, but complication is a condition where the patient will have a lot of fibrosis, progressive fibrosis, also called as a PMF. What is that? Progressive massive fibrosis. Progressive massive fibrosis. Progressive massive fibrosis. It is so massive that it may even lead on to death also. That it may even lead on to the death also, right? So it's called progressive massive fibrosis, leading on to the death of the patient. But fortunately, it is not something which is common. That is what I want you to remember. Common type is simple type. Simple type means patient is usually asymptomatic. Okay. And some patients with a cold workers pneumoconiosis, they can have something called Kaplan syndrome. This is an important one-liner MCQ question. What is Kaplan syndrome? Kaplan syndrome is a condition where patient is having this cold workers pneumoconiosis, but in addition, he is having something like rheumatoid arthritis. Rheumatoid arthritis, or something like nodules. We call it rheumatoid nodules. In your rheumatology section, you will learn about it. Something like in the skin area, around the joints and all, they have the nodules. That is called rheumatoid nodules. When rheumatoid arthritis or nodules are present along with the Kohlbuck's pneumoconiosis, it is called as Kaplan syndrome. Just note the name alone. That is enough. Okay, it's called Kaplan syndrome. Just like a one-liner question. That's all. Okay, so that is what is Kohlbuck's pneumoconiosis. The other type of pneumoconiosis I have already mentioned. Just like you have to remember the names depending on the exposure. What is that? Sugarcane exposure. It is called vagasiosis. Cotton exposure, like cotton industries and all, it's called dysinosis. You think like cotton is a very important business, so it's called dysinosis, like that you can remember. Tin is called stenosis. Iron is something which you might have heard in your pathology class, other classes also, right? Iron means like hemosiderin and all, right? Siderosis. That's why it's called siderosis. Just the names you have to remember. But I feel two important things which you have to know a little bit in detail are pneumoconiosis and silicosis. Sorry, there's silicosis and asbestosis. These are the two things which I want you to remember quickly. Okay, right? Fine. So just a summary, pneumoconiosis is something which will develop over a long period of time in relation to occupations. Okay, more than 10 years at least. Silica, the important points which should come to your mind are: this is the most common overall type. It is usually exposure in stone miners or stone grinders. That is what you need to remember, and usually affects the upper lobe, and it's a very dangerous condition because it leads to progressive fibrosis. The characteristic X-ray finding you should remember is always the eggshell calcification. Whereas asbestosis is something related to textiles or shipping industry. The point about this asbestosis is that mostly it is a benign condition only in the form of pleural plaques, or it is the earliest manifestation will be in the form of pleural effusion. That's all. However, over a long period of time, it can lead to complication of lung cancer. And most important thing is the specific type of lung cancer with asbestosis is mesothelioma. These are the important MCQ points which are commonly asked in your exams. Okay, right. So that is about the section of pneumoconiosis. I think with that we will have the lunch break now. Now the time is 1:35. Right? Now the time is 1:35. Can we start the class around 2:20, 2:30 like that? Is it fine? 2:30, can we start the session? Okay, so all right. So I'll start the class around 2:30. Okay, fine. Right. Okay. See, I can see now that many of you have messaged in the programs also, but I will not be able to see that frequently. That is the only thing. But of course, if there are any issues, what you can do is you can just send it in this chat section. It is something which is very urgent. You want me to repeat and all. It is like that. But other things you can send in Telegram, but only thing I will not be able to see frequently. Okay, right? Any doubts also you can leave it there. I will reply it back at a later time. Okay, fine. So we will start the session at around 2:30. Okay, fine. 2:35, 2:45 will be very late out because I have to end the session by around 5:30. That is what they have given me time, because 6 o'clock there is another session which is starting also. Okay, so let's keep it at 2:30.